ഡോക്ടർ ഇനി ആ പവർ പോയിന്റ് എടുത്താൽ മതി, പവർ പോയിന്റ് ടാസ്ക് ബാറിൽ നിന്ന്. എത്തിക്കോ.
ताली चुमके ने अम्मी चुमके ने आम चुमके ने आम चुमके ठीक है संख्या ओके
ഞാൻ ആ പാട്ടിട്ടേക്കാൻ വേണമെങ്കിൽ ഇപ്പൊ തുടങ്ങണ വരെ ഒരു ബോറടിക്കണ്ട. നിർത്താറാകുമ്പോ പറഞ്ഞാൽ മതി കേട്ടോ. വസീം രണ്ടുപേര്, സ്പീക്കറും വസീമും ഉണ്ട്. ആരാ ചെയർ ആരാ? ഇപ്പൊ എന്താ കാണുന്നത്? പാട്ട് എന്താ മ്യൂസിക്കിൽ എന്താ കാണുന്നത്? അല്ല നമ്മുടെ ആപ്പ് ഒന്നും എടുത്ത് ഇതല്ലേ കറക്റ്റ് അല്ലേ? മ്യൂസിക് കേൾക്കണ്ടല്ലോ. ഓഫ് ചെയ്തിട്ട് കേട്ടോ, എല്ലാവരും ഓഫ് ചെയ്തിട്ട് കേട്ടോ മറ്റേ സൗണ്ട്. ക്ലിയർ ആയിട്ട് കേൾക്കണ്ടോ സൗണ്ട്? ഞാൻ നോക്കില്ല, അല്ലെങ്കിൽ അല്ല ചിലപ്പോ ഒരു കാര്യം ഞാൻ നോക്കിയില്ല.
റോബർട്ട് സാർ, ഗുഡ് മോർണിംഗ് സാർ. സാർ, ഞാൻ റോയിയാണ്, സാറിന്റെ പഴയൊരു സ്റ്റുഡന്റ് ആണ്, കോഴിക്കോട്. ഹലോ സാർ. മ്യൂട്ടാണ് സാറേ, സാറ് മ്യൂട്ടാണെന്ന് തോന്നുന്നു. സാർ,
ഡോക്ടർ റോബർട്ട് സംസാരിക്കാം. ഞാൻ അൺമ്യൂട്ട് ചെയ്തിട്ടുണ്ട്. കേൾക്കുന്നില്ലായിരുന്നു നിങ്ങള്? ഇപ്പൊ സംസാരിക്കുമോ ഒന്ന്? അല്ലല്ല, കേൾക്കുന്നില്ല.
സാർ കേൾക്കുന്നില്ല. ഇല്ല ഇല്ല, കേൾക്കുന്നില്ല സാർ.
ഒന്ന്
മ്യൂട്ടാണ് സാറേ.
അല്ല, പിന്നെ മ്യൂട്ട് ചെയ്തു.
മ്യൂട്ടാണ് സാറേ.
ഇപ്പൊ അൺമ്യൂട്ട് ചെയ്തു, പക്ഷെ മൈക്ക് കേൾക്കുന്നില്ല. പറയുന്നത് കേൾക്കുന്നില്ലല്ലോ. മൈക്കിൽ വല്ലതും കുത്തി വെച്ചിട്ടുണ്ടോ? മറ്റേ ജാക്ക്
മാറ്റിയാലും മതിയായിരിക്കും.
ജാക്ക് വല്ല ഹെഡ്ഫോൺ ജാക്ക് കുത്തിയോ? അങ്ങനെ വല്ലതും കുത്തി വെച്ചിട്ടുണ്ടെങ്കിൽ. ഇപ്പൊ എന്ത് വന്നു? അല്ലല്ല.
ഹലോ
ഹലോ. ഇപ്പൊ കേക്കാം. കറക്റ്റ്.
അപ്പൊ ഇത് മതിയോ?
മതി.
സ്ലൈഡ്സ് പ്രൊജക്ട് ചെയ്യാൻ പറ്റുന്നില്ല.
അത് ഞാൻ എങ്ങനെയാ? അല്ല, ഞങ്ങള് തുടങ്ങിയിട്ടില്ല. അതാ ഷെയർ ചെയ്യാൻ കൊടുത്തു തുടങ്ങിയിട്ടില്ല. ഒരു ഇൻട്രൊഡക്ഷൻ ഒക്കെ ഇവിടുന്ന് ഇൻട്രൊഡക്ഷൻ ഉണ്ടേ. അല്ല, ഇവിടെ ഒരു ഇൻട്രൊഡക്ഷൻ കൊടുക്കും. അത് കഴിയുമ്പോ തന്നെ ഡോക്ടർക്ക് കിട്ടിക്കോളും. പിന്നെ ഷെയർ ചെയ്യാം.
ഓക്കെ, അപ്പൊ സൗണ്ട് ഇത് മതിയല്ലോ അല്ലേ?
സൗണ്ട് മതി, മോർ ദാൻ എനഫ്. വെരി ഗുഡ്.
റോബർട്ട് സാർ സുഖമല്ലേ സാറേ?
കുഴപ്പമില്ല, അങ്ങനെ പോകുന്നു.
സാർ ഇപ്പോഴും അതുപോലെ തന്നെ ഇരിക്കും, ചെറുപ്പായിട്ട് തന്നെ ഇരിക്കുന്നു.
മേക്കപ്പും കാര്യങ്ങളൊക്കെ ഉണ്ട്, കുഴപ്പമില്ല.
പ്രശാന്ത് അവിടെ സ്ലിം ബ്യൂട്ടി ആയിട്ടിരിക്കുന്നു. പ്രശാന്ത് 10 വയസ്സ് കുറച്ചു, 20 കിലോ 10 വയസ്സ്.
എല്ലാരും മഴയത്ത്
സ്റ്റുഡന്റ് ആയി. അരുൺ ഗോപി, ഗുഡ് മോർണിംഗ്. ഉറങ്ങിയ?
ഹലോ.
മോർണിംഗ്.
ഗുഡ് മോർണിംഗ്.
റോബർട്ട് സാർ ഉണ്ട്. റോബർട്ട് സാർ എന്താ കണ്ടില്ലേ?
സാറിന് ഓർമ്മ സാർ, ഞാൻ ആക്ച്വലി സാർ കുറച്ച് പഠിപ്പിച്ചു സാർ, പക്ഷെ ഞങ്ങൾ പിന്നെ അവിടുന്ന് പോയി. സാറിന് ഓർമ്മ കാണാൻ വഴിയില്ല. ട്രിവാൻഡ്രത്ത് ഞാൻ ഷബീറിന്റെ കൂടെ തന്നെ ആയിരുന്നു സാർ. ഷബീറിന്റെ കൂടെ തന്നെ ആയിരുന്നു. ഷബീറിന്റെ സെയിം ബാച്ച് തന്നെ ആയിരുന്നു സാർ. സാർ ഇപ്പൊ സുഖമായിട്ട് പോകുന്നില്ലേ?
കുഴപ്പമില്ല, അങ്ങനെ എന്ത് സുഖം, അങ്ങനെ പോകുന്നു.
അതിലെ സാറിന്റെ പ്രായ മമ്മൂട്ടിയെ പോലെ ഇരിക്കുന്നുണ്ടില്ലേടാ?
കുറച്ച് കടുത്തു പോയി.
ചേട്ടൻ രാവിലെ എല്ലാരും ഒന്ന്
ഷബീർ അല്ലേ? അവ ഇന്നലെ ലേറ്റ് ആയ കാരണം രാവിലെ തുടങ്ങുമെന്ന് പറഞ്ഞിട്ട്
ഷബീർ ഉണ്ട് അതിനകത്ത്. ഷബീറിനെ കാണുന്നുണ്ട്. ഷബീർ പക്ഷെ മ്യൂട്ടാണ്. പക്ഷെ ഇപ്പം സ്റ്റാർട്ട് ചെയ്യാറായി കാണും.
എന്തുകൊണ്ട് സാർ, സുഖമാണല്ലോ?
കൊള്ളാം, എന്തായാലും വൻ പരിപാടി. കൺഗ്രാജുലേഷൻ.
താങ്ക് യു സർ. റോയി ഇല്ലേ ഇവിടെ?
എവിടെ ഉണ്ടാ?
ക്യാമറ ഇടാ.
കൂടുതൽ ക്യാമറ വെച്ച് കഴിഞ്ഞാൽ എന്റെ ടി വി പിടിക്കുന്നതാണ് അവര് പറയുന്നത്.
ഓക്കെ, മോർണിംഗ്.
കരൺ കയറുന്നാണല്ലോ പറഞ്ഞത്, കാണുന്നില്ലല്ലോ. അജിയുടെ പോയി. അജി രാവിലെ റോബർട്ട് സാറിന് ഡോക്കാണ്ട് രാവിലെ എത്തുന്ന പറഞ്ഞു.
Sir, shall we start?
Please.
Okay, 1 second, sir. 1 second. Sir, അപ്പൊ ഞങ്ങള് സ്പീക്കർ ഒഴിച്ച് ബാക്കി എല്ലാവരും ഒന്ന് മ്യൂട്ട് ചെയ്യാണ് സർ. താങ്ക് യു. ഓക്കെ, മോർണിംഗ്. ഹലോ. ഫൈൻ. ഓക്കെ. യെസ്, മോർണിംഗ്. മോർണിംഗ് ദീപ, ഇസ് ഇറ്റ് ഓക്കെ? കേൾക്കാമല്ലോ? അത് ഇവിടെ ഇത് പറഞ്ഞു.
കേൾക്കാം സർ.
ഇതെന്താ വോളിയം കിട്ടും? മോർണിംഗ് ദീപ. ഓക്കെ, കേൾക്കുന്നില്ല. കേക്കാവോ? ദീപ പറയുന്നത് കേൾക്കുന്നില്ല. സൗണ്ടാ.
ഹലോ,
അല്ല, ഞാൻ ഇപ്പൊ അയച്ചു, സാറിന് അയച്ചു, വെയിറ്റ് ചെയ്യാം. ദീപ, മോർണിംഗ്. എനിക്ക് തോന്നുന്നു we can't hear you. അല്ലല്ല ദീപ, കേൾക്കുന്നുണ്ടോ? അല്ലല്ല ദീപയുടെ 1 second. 1 second ദീപ. അല്ല, what happened? Can anyone hear the voice of Deepa? Sir, Robert sir? No. Prashant? No. Deepa, ആ മൈക്കോ അല്ല, അതൊന്ന് ഓൺ ചെയ്യുക. അല്ലെങ്കിൽ ആ ജാക്ക് കറക്റ്റ് ആയിട്ട് കുത്തിയിട്ടുണ്ടോ? അല്ലെങ്കിൽ അത് മാറ്റിയിട്ട് സംസാരിക്കുമോ ദീപ? അല്ല, ഇപ്പൊ ജസ്റ്റ് കേട്ടതുപോലെ തോന്നി, അത് ഒന്നുകൂടി കണക്ട് ചെയ്യോ? Yeah. I think now it's okay. You start. അല്ല, ആ മൈക്കിൽ തന്നെ സംസാരിക്കോ? വേറെ ആരുടെയും സൗണ്ട് ആണോ?
അമ്പിയമ്മ, അവളെ ഒന്ന് വിളിച്ചാണ്.
ഫൈൻ. സിബിസാറിന്റെ സൗണ്ട് ആണ് കേൾക്കുന്നത്. ഓക്കെ. ദീപ, still I think some volume issues. Fine, no problem Deepa. What's the time now? Short time? 9.
I think just clear the issue.
Robert sir, 1 minute. Okay. ദീപ വിളിച്ചതാണോ? കോൾ ദീപ. വീഡിയോ കട്ട് ചെയ്തു. യെസ്.
ഹലോ.
യെസ് സർ, മോർണിംഗ്.
ഗുഡ് മോർണിംഗ് സർ.
കിട്ടുന്നുണ്ടല്ലോ സർ?
ഉണ്ട്.
സ്ക്രീൻ മുഴുവൻ സാറിന്റെ ഫേസ് കവർ ചെയ്തിരിക്കുകയാണ്.
മാറ്റിത്തരാം.
വേണ്ട, നിന്നാ നല്ല കുഴപ്പമില്ല സാർ. So today's session we are going to start, and today's session's day is supposed to start with Deepa. Note session, introductory remarks, just 30 seconds by Dr. Deepa. We are waiting for that. Some technical issue with Deepa. Let me see. We'll wait for another 30 more seconds. Sivi sir, now it's perfect. Okay. സാറിന്റെ ബാക്കിൽ ഒരു ലൈറ്റ്, ആ ലൈറ്റിനെ ഒന്ന് സൈഡ് ലൈറ്റ് ഉണ്ടെങ്കിൽ ഇപ്പൊ ഓക്കെ മതി സാർ. പെർഫെക്റ്റ്. ഇതില ഇനിയിപ്പോ കുഴപ്പമില്ല. I think there is some technical issues with Dr. Deepa. So no issues, but we will straight away start with our sessions. Today is our second day. We had some more than 30 to 35 sessions yesterday itself, and today also we have some 20 to 25 sessions today. Today's first session is something regarding ABC of diabetes, that is A1C, blood pressure and cholesterol. So some topics related with these common like issues. So first session will be chaired by two eminent doctors from Kerala. One is Dr. CBNS, who is the professor of medicine, Medical College Trivandrum, and he is also my teacher. And another is Dr. Prashant Shankar, my very good friend and my dear colleague. Dr. Prashant is the consultant physician, Muthoot Hospital, Pathanamthitta. So over to you, chairs.
Can you hear me?
Yes, sir. Yes, sir. Please.
Hello, and welcome all to the second day of the Diabetes Today 2020. And as in yesterday, we are going to have an excellent academic feast. And the first topic is by none other than Dr. Robert Matthew. He is a well-known neurologist in Trivandrum and Kerala. And he is going to talk on diabetic neuropathy, a real headache for all physicians. And Dr. Robert Matthew is a professor in neurology and consultant neurologist in Kerala. He is the director of Anugraha Neurocare Center in Trivandrum. He was professor and head of the Department of Neurology in Government Medical College, Alappuzha. He was a very wanted teacher for all students. His interest is in dementia especially, and he did his fellowship in dementia at Neuroscience Research Australia. And over to you, sir. Hello. Hello, Dr. Robert.
Yes, sir.
You can start the presentation.
Sir, Robert Matthew, sir, kindly unmute, sir. Robert Matthew, sir, kindly unmute. We will do. Yeah. Okay, sir. Please carry on.
Okay, no?
Okay, sir.
Okay. Thank you very much, Professor Sibi, for those kind words of introduction. And I thank Dr. Sabi for organizing such a wonderful conference and giving me this opportunity to discuss something about peripheral neuropathy in diabetes in the morning session itself. So the heading was that management of peripheral neuropathy in diabetes is a nightmare. Actually, it is, if you it is no more a nightmare. It's all well standardized, and there are definite guidelines. You just have to follow one of them, and it will be easy. Now, are my slides being shown or?
No,
Hello?
no. Please share your slides now. You have the access.
Okay. So.
No,
Slide.
sir. No, sir.
No.
Start sharing. You can just share the slides.
Okay.
Sir, meanwhile, sir, Sibi sir, kindly log out from the second one. I think some echo issues are there. From mobile, I think. Sibi sir, I think 2 login IDs, sir. Sir, yeah, Robert Matthew, sir, it's perfect now. Yes, the slides are coming. Just a moment. And Sibi sir can log out from the second link. Second device, maybe mobile. It's echoing. Yeah, slides is slowly coming, sir. We are waiting for that.
Okay. So I'll just start. So my idea will be to I'll finish off in 10 minutes. I'll just touch up the important things and then 2-3 minutes of discussion. So
1 second, sir. 1 second.
Yes.
The slides noted Reach. Yeah, sir. Can you make in the slideshow mode? Just switch the slideshow mode. That logo. Please click that.
Okay.
At the bottom side. No, sir. No, sir. That's like usual slideshow logo, sir.
Okay. Just give me 1 minute. Okay. Hello.
Yeah. Perfect, sir. Perfect.
Okay.
Please carry on.
That's a list of the various neuropathies in diabetes. So we'll be dealing only with the first one, diabetic sensory peripheral neuropathy, or primarily a small fiber neuropathy. This is what we are going to touch upon in next 10 minutes. These are the other ones. You can have diabetic autonomic neuropathy. You can have mononeuropathy in diabetes. You can have radiculopathy, polyradiculopathy, etc. By and large, the commonest in diabetes is the distal sensory peripheral neuropathy. It's also called glove and stocking type of neuropathy. And it is basically due to small fiber involvement. So it's also called small fiber neuropathy. And this is the topic for today's discussion. This is the pattern. It can be just a stocking involvement or a glove and stocking. Quite often we see this pattern where there is just a stocking, and once in a while we do see the glove and stocking also. Just to touch upon, there will be hyperglycemia, which triggers multiple events. Finally, there will be nerve injury, and from the injured nerve, there will be abnormal discharges. And this will result in diabetic neuropathic pain. So, happens in diabetic sensory peripheral neuropathy. Of course, other factors also play in, like hyperlipidemia also can lead on to oxidative stress, and also trigger some cascades, and they also add nerve injury. Just about the investigation. Your patients, the diagnosis of diabetic neuropathy is based solely on and examination. You don't need to go for investigations. Objective confirmatory testing is used in research setting or as part of diagnostic workup of patients with atypical clinical presentation. So by and large, you don't need a detailed investigation for patients with diabetic sensory. So some important points that you have to remember about small fiber neuropathy. Small fiber neuropathy, physical examination can be normal. So that's very important. So you may think that patient is inappropriately complaining because there may not be sensory loss, then there may not be paresthesias. Even nerve conduction study can be normal. Remember that. We consider nerve conduction gold standard in neuropathy. Small neuropathy, the gold standard is intraepidermal nerve fiber density. So this is by doing a nerve biopsy. It needs a specialized expertise. I'm not aware of a center where this is being done on a reliable way. So in our setup, for all practical purposes, small fiber is a clinical diagnosis. This is a picture which I got from the text only. So the panel B shows the arrows are showing the nerves. Are the nerves in the epidermis, and here the number of nerves have reduced and they have become thinned out also, and this is a nerve branch. So the density compared to B, the density in C is less. So that is how small fiber neuropathy is diagnosed based on it. Right. So more than half of all neuropathies are diabetic neuropathies, and 50% of diabetics, in some studies it is 75% of diabetics have neuropathy, and 50% of the diabetics with neuropathy develops neuropathic pain. So it's a big number. So okay. So basic guidelines for any neuropathic pain approach to treatment. So treatment of neuropathic pain is just pharmacological treatment for all practical purposes. There are other treatment options also which are needed in very, very rare situations. So it's a pharmacological management of diabetic peripheral neuropathy. Some very, very things. If you don't follow this, then the management becomes a nightmare. Always discuss with the patient a principle of trial and error approach. Like the first medicine may not work, you may have to go for a second one. Like also the first dose may not work, you may have to increase the dose. So it is basically a trial doing things. So you'll have to discuss the principle of titrating the drug dosage. Always start with milder ones, the pain, or just to give some relief of the pain. Don't go for a very, very aggressive treatment in the first hand itself. Start with a very small dose, and so patient may have to come for frequent visits or to have a schedule where you titrate it in advance. But this is very, very important. It is not like a single prescription and sending the patient off. And increase the dose if the pain relief is inadequate and side effects are absent or tolerable. Don't be focused on the symptoms alone or the pain. Patient is saying no improvement in pain. Don't suddenly increase the dose. See how he is tolerating the medicine. So it should be very slowly. And if the drug is ineffective at high dose, or if side effects prohibit dose escalation, then stop the drug and choose another one. Here also, when you're stopping, remember, if you stop it abruptly, then the pain may come again. So you can go for something like an overlap. You continue with the present medicine and then add the new one. And once the new one has taken over, you can try to reduce the first one. And if the drug has been partially successful, so some relief is still patient is not comfortable, then you can do this. So you can go for combination also once done. So withdrawal I have already mentioned, and we are introducing a new treatment, consider an overlap. After starting or treatment, not weeks, you'll have to review the patient just to see how patient is tolerating it, and then only go to the patient. If a patient has a which is working for him, unless there's a definite contraindication, please don't try to change it. It will be a therapeutic misadventure. Just try to increase the dose, titrate it, and still, if it is not adequate, then you can add another one. Oh, very sorry. So this is just to show, this is just a list of some of the studies. I just want to highlight this part, the outcome. So there's a 30% improvement. Here there's a 30 or 50% improvement. See, all studies 30, 50, 30, 50, 30, 50 like that. So the point which we have to emphasize or impress upon the patient is that by treatment, we are aiming at 30% relief or 50% relief. It is not like we are abolishing the pain. Second point, it's purely a symptomatic treatment. It's one. The treatment is going to be prolonged. It may be it may have to be continued for say weeks. So if we have a whole set of drugs, so which to select? So we have one group of drugs which are recommended by scientific bodies, and there are other drugs which are found to be of use but not yet endorsed by scientific bodies because of lack of enough evidence to really support it. So this is a list. These are the drugs recommended by AAN, American Academy of Neurology, and this is as per their recommendation. But different countries and different bodies have different. The Prevalence is the one which has a lot of scientific support or evidence base as diabetic peripheral neuropathy pain. Which is the best one? So which do you select? This is a very, very interesting one, which I always find as a steady, ready reference. So this shows the number of number needed to treat, and then so the lesser the number needed to treat, the so in that way, tricyclic antidepressant appears to be very good, and that is true also. The size of these dots, that is how robust the clinical evidence supporting it is. So a lot of studies has been done on gabapentin, pregabalin. Studies on tricyclic antidepressants are not, and that is one of the reasons why it doesn't enter into the guidelines of some of the prominent scientific bodies. This is the next slide. So you have three major groups of drugs. One is convulsants. Second is SNRIs. And this tricyclic antidepressants. Three major groups are there. So you can select, you can start treatment from one group, and try to titrate, and if there is not much of relief, you can go for the next group of the three groups. And you try groups and you're not getting result, then you can try combination from within these 3 groups. So this is basically very, very brief one. But I think this will be the best one to practice in our daily practice. So 3 groups are there. So if you're thinking of anticonvulsant, the prototype will be pregabalin. If you're thinking of SNRI, the prototype will be duloxetine. If you're thinking of tricyclic antidepressants, it will be amitriptyline. So one of this, start, titrate, no improvement, try another one, titrate, no improvement, try a combination. It's that, and the patients will have good consequences. So this is a little more expanded. The voltage gated and these are the anti-epileptics. So the commonly used ones are pregabalin and gabapentin, and the maximum evidence is for pregabalin. And then you have the SNRI, serotonin norepinephrine reuptake inhibitors, duloxetine and venlafaxine. And duloxetine is easily available. And then you have the tricyclics. Now, I've already covered just one word about the opioids. So opioids like say tramadol, tapentadol should be used only as the third tier. To try single medicines doesn't work, you go for combination doesn't work, then only go for one of these opioids. This slide is very see just to highlight the dose of pregabalin. The effective dose is 300 to 600. Gabapentin effective dose is 900,600. SNRI effective dose is 60 to 120. Just 1 point. How do you select the drug? Select the drug based on the drug interactions and cost, comorbidities, adverse effects. So cost is very, very keep that in mind. So this is the dose which we have to try, and I'm very sure that many of us, including myself, doesn't reach this dose in majority of our patients due to various reasons. This is the tricyclic antidepressant, and that's a dose of tramadol. Okay, so that's in a nutshell the major drugs and how to select it. And there are a number of side effects. This is actually the placebo percentage of placebo who has side effects, and this is from the patient. So side effect is there, but by and large you have to start at a very small dose, and if you titrate, then side effects may not be too much. So first level will be pregabalin and duloxetine. Opioids, try to avoid as. Just highlight one point. Many of the studies, or most of the studies, they don't look at the quality of life. That's very, very important, because this is purely a symptomatic treatment. So even if you don't treat, nothing is going to happen. But if you're treating, make sure that the quality of the life improves. The pharmacoresistant neuropathic pain doesn't get at least 50% relief. And, try different at least for 1 month. That becomes a pharmacoresistant one, which is very, very, very rare. If you are strictly adhering to the dose, slow titration, I think 90% of our patients will have good relief just with medicines. Only for pharmacoresistant pains, you need to go for interventions, which is not part of this talk. I think I have just covered the important things. Shall I take some questions? How do you exit from this?
Hello. Yeah, thank you, Dr. Robert. We will take the questions at the end of the session. Is it okay for you? Or?
Oh, okay. So session ends at what time?
Hello.
Hello.
Yes, we can hear you.
Okay. So what time does the session end? Hello?
The session is fine. You know, it is kept at its time. You can ask the questions.
Okay. Okay.
Oh, okay. Now you can take the questions right now. The questions from the audience.
Or
Hello.
I'll finish off my slides if there are no questions, if I have time. Otherwise, I'll wind up.
Dr. Robert, I have a doubt. You
Yes,
said
sir.
90% of the patients will respond to pharmacotherapy. In practice, this is not the truth. I agree that we are not going to the recommended dosages, which is very difficult.
Correct. And be careful about the cost factor also. Like if you're starting gabapentin, and if you are trying to titrate it to say 1000 milligram per day, it will be easily more than say 50 rupees per day. And they will have to buy it for at least 3 months. So
Okay,
that part
that's
has
fine.
to be considered. And they have to be counseled as regards what they are going to attain and all. Then they may stay.
And with regard to pregabalin, with such a dose, what about the incidence of side effects like increase in sleep, weakness, and all those things?
If it is titrated slowly, 150, 225, up to that is well tolerated. So this is my personal experience. But literature says that even 600 is okay. But I think 150 to 225 is easy. Only thing is you go little slow. Maybe you will increase the dose every 2 weeks or even every month.
Yeah. Any other questions? We will continue, Robert, sir.
Pardon me?
Actually, the time is over.
Over. That's enough.
Yeah.
Okay. Thank you very much, Professor CB sir and Dr. Shabir for this wonderful opportunity.
Thank you, Dr. Robert.
Sabir sir, shall I move forward second?
Yeah,
please.
we will go to the next topic. Oh, to Dr. Prashant.
Okay. Good morning to all. For the morning of diabetes today, we had an excellent day yesterday. It is continuing today also. So once again, I thank Dr. Sabir for giving another opportunity. So I will straight away introduce the speaker. Dr. Arun Gopi is a well-known figure. He is currently working as a director and head Department of Electrophysiology and Heart Failure and consultant cardiologist at Metro International Cardiac Center. He had his MBBS from Government Medical College Trivandrum and Kerala and gold medals in medicine, surgery, pediatrics, and ophthalmology. And he was working previously as the assistant professor of cardiology at Pariyar Medical College. He has attained the Youth Investigator Award for paper on mitochondrial mutation in long QT syndrome at the Asia Pacific Heart Rhythm Society in 2012. He is also the fellow of American College of Cardiology and the fellow of European Society of Cardiology. So over to you, Arun Gopi sir, for your lecture.
Yeah, thank you, Prashant. Shabir and his team at TDRF for this opportunity and to continue the proceedings. I have been assigned the job to discuss the B of diabetes, that is blood pressure control. I'm just trying to share my slides. I hope my slides are visible.
Yes, sir. Yes, sir. Yeah, it's visible.
Yes, sir. Make it in the slideshow mode.
Yes. Mode and can I go ahead?
Yeah. Perfect.
Yeah. I'm pretty sure this August audience does not require any insights into the typical management of hypertension in diabetes. So, but I've taken the liberty on discussing one of the so-called slightly uncommon but difficult to treat scenario in hypertension, that is resistant hypertension. To set the ball rolling for this topic, we all realize that hypertension is simply the single largest contributor to mortality worldwide. In fact, it's not not simply called a silent killer. In fact, the largest mortality is attributed to this disease alone. For every 20 millimeter systolic rise in blood pressure, there is a doubling of 10-year cardiovascular mortality, and it dramatically increases the risk of stroke, hypertension, heart failure, and renal failure. The reason why this is contributing so much to mortality is just because only 50% of hypertensives reach the established target. You look at this figure, simply 30% of hypertensives are 35% are treated but poorly controlled. It's only 1/3 of patients who are treated and adequately controlled. And compounding the factor is the very high prevalence of this disease. In fact, 1 billion is affected and is projected to increase to 1.6 billion by 2025. India is in no different pace. In statistics, the prevalence of hypertension is common across all geographic settings and socioeconomic status. In fact, the prevalence is close to 25%. And as with any of the other cardiovascular disease in India, this tends to affect the younger population, at least 10 years younger than the Western population. That is why we need to really understand and manage this disease aggressively. And one of the difficult scenarios in this subset is resistant hypertension. So, all from the American Heart Association scientific statement on resistant hypertension. By definition, it is defined as blood pressure which remains above the target goal despite concurrent use of 3 antihypertensive agents of different classes, which should include a calcium channel blocker, a renin-angiotensin receptor blocker, either an ACE inhibitor or an ARB, and a diuretic. So all these agents should be administered to the maximal tolerated dose at appropriate dosing frequency. And despite that, if the blood pressure target is not achieved, that is when you call it a syndrome of resistant hypertension. That giving 3 antihypertensives to the maximum tolerated dose and despite that not achieving blood pressure control is uncommon. But that's not what the studies say. If you look at the studies across the globe, the prevalence is close to the tune of 19 to 18% of overall hypertensives that you see in your routine practice. And look at this subset of patients, you realize that most of them have multiple comorbidities. They are elderly, they are diabetic, they have albuminuria, they are obese, and one of the commonest coexisting comorbidity is obstructive sleep apnea. If you look at our scenario, what is the single most common cause of resistant hypertension? You look at this picture, it summarizes the real story. People going to hospitals to get their blood pressures checked, people at home measuring the blood pressure of coffee or an exercise, or at camps, in this way the blood pressures being measured in proper technique. You can see in this last picture the blood pressure being measured on one arm and the blood sugar being measured on the other arm, and you say that, oh no, the BP is not controlled, we need to increase the drugs that you are on. And this is the major fallacy of diagnosis of hypertension, what we call as pseudo-resistant hypertension. In fact, a poor office blood pressure measurement technique or a poor adherence to the prescribed drugs are in fact the most commonest cause of resistant hypertension in clinical practice. Not to forget the white coat hypertension or the clinical inertia on the physician's part to not titrate the doses to the maximal tolerated dose and thereby not giving patient the maximum benefit of the drugs which he should get. We have excluded pseudo-resistant hypertension. This is the AHA algorithm for evaluation of resistant hypertension in your clinic. It goes step by step. First is to confirm treatment resistance. That includes that you have a clinic blood pressure reading which is more than 130/80 millimeters of mercury and the patient is taking at least 3 or more antihypertensives, which include a long-acting calcium channel blocker, a blocker of the renin-angiotensin system, which includes either an ACE or ARB, and a diuretic to the maximal tolerated dose. Once you have confirmed resistance, next is to exclude pseudo-resistance by confirming adherence to the therapy that has been given. The ideal way of doing this is to do a 24-hour ambulatory blood pressure monitoring, which is definitely going to exclude the effect of white coat hypertension. Step is to assess for secondary causes of hypertension. You're pretty sure of the numerous causes of hypertension. Secondary hypertension, which includes the renal parenchymal disease, is the most common entity. Endocrine causes like primary aldosteronism, Cushing syndrome, pheochromocytoma, paraganglioma, vascular etiologies like renal artery stenosis, coarctation of iota, and obstructive sleep apnea are the commonest causes of secondary hypertension, which need to be addressed before up-titrating the drugs in such a scenario. Next is to understand the magnitude of problem, that is, look at the target organ damage, look at the fundus of the patient, examine for evidence of left ventricular hypertrophy either by an electrocardiogram or an echocardiogram, look at the nephropathic damage the hypertension is caused by looking into proteinuria, the estimated GFR, and the extent of atherosclerosis by looking at the ankle brachial index, which gives a surrogate marker of the peripheral arterial tree. assessed and worked up your patient with resistant hypertension by excluding secondary cause of hypertension and optimizing his drug regimen. How do you manage this patient in your clinic? The first step is to ensure low sodium diet, which you all know means that the daily sodium intake should be less than 2.4 grams, ensuring the adequate lifestyle modifications in the form of good protein intake, ensuring weight loss, regular exercise with at least 6 hours of uninterrupted sleep. After all this therapeutic lifestyle modifications, then we look up into the pharmacotherapy. The first step is to substitute to an optimally dosed thiazide diuretics, which include chlorthalidone or intepamide to the maximal tolerated dose. So first step is to have an optimally dosed thiazide diuretic. If BP is still not under control, the next step is to add a mineralocorticoid receptor antagonist, that is spironolactone or ipralnol, which is seldom used as an antihypertensive in our clinical practice. This is one key message from this this algorithm, that spironolactone should come higher up resistant hypertension before we add the other vasodilators. Step 4 is to hit at the sympathetic nervous system again by adding a beta blocker. If the resting heart rates are more than 70 beats per minute, you can add a cardioselective beta blocker like bisoprolol or metoprolol succinate, or you can add, in especially cases of pregnancy-induced hypertension, a combined alpha beta blocker like levetiracetam. If beta blockers are, the next step is to look at blocking the central sympathetic drive by using clonidine or moxonidine. Then step 5 is to add vasodilators. The best vasodilators we have at the moment is prazosin and hydralazine in a dose of 25 mg thrice daily. All of these being titrated to the maximal tolerated dose. If despite all these things, blood pressure is still not controlled, you look at really experimental drugs like minoxidil is not commonly available. And then despite all these trial and error with all the pharmacological agents that we have, if still blood pressure, that's when we really look at some invasive approaches. And one of the invasive approaches which has been studied and was in controversy for some time is renal denervation. This all stems down from the basic understanding that the central driving factor in resistant hypertension is the renal sympathetic overactivity. And the key pathogenic substrate in the renal sympathetic hyperactivity is the renal afferent nerves, which arise from T10 to L2, which arborize around the renal artery and travel via the renal adventitium into the renal vascular territory. And this has been targeted. It is simply what we call renal denervation by using ablation, by using a catheter via the conventional axis, just about 4 to 6 2-minute treatment approaches on each renal artery is what is done in renal denervation. And this is an animation of how it's done. It's not a very complicated procedure. Just like any percutaneous intervention in the renal vascular artery, you have an access to the renal artery, taking a catheter through this catheter, taking a specialized device which is able to deliver the ablation therapy through this catheter, get into the renal artery, go across the entire circumference of the renal artery, give about 4 to 5 multiple ablations inside the renal artery, and thereby disconnect renal nerves by getting into the juxtaglobin apparatus and driving their excess sympathetic activity. So once you have denervated the kidney, hypertension becomes more amenable for blood pressure control. And we had some fascinating results from Simplicity Hypertension 1 trial, which was the proof of the concept, which showed that it's a very simple procedure, average procedure time of 40 minutes, no major complications, and significant reduction of blood pressure to the tune of about 30 millimeters of mercury. And the response rate to this therapy improves over time. You can see at the end of 3 years, the response rate was close to 100%. And despite having some fascinating results in the first trial, the second Simplicity Hypertension 2 trial, the first sham-controlled prospective randomized study of Simplicity Hypertension 3 was a real disappointment that it did not show any benefit. And so this therapy went into disrepute, but of late, they have modified the catheter, and using a different catheter, they have found some positive results in the denerve hypertension trial and the spiral hypertension of medicine study. And I'm pretty sure renal denervation is going to come back and is going to be one of the best sought after therapy in resistant hypertension. But that all patients are not suited for this therapy. If there is really resistant hypertension and the patient does not have established renal parenchymal disease with the estimated eGFR being more than 45, And the patient should have a suitable renal anatomy, that at least one main renal artery, which is more than 4 millimeter in diameter and more than 20 millimeter in length, is an important criteria for doing this therapy in patients with persistent hypertension. We were doing this in our conventional EP lab using the conventional catheters that we have, and we found some good results. But now we are still awaiting the more evidence from trials before using it in all cases of resistant hypertension. So, ladies and gentlemen, respected chairs, to conclude, resistant hypertension is defined as above goal elevated blood pressure in a patient despite the concurrent use of 3 antihypertensive agents, which should include a calcium channel blocker, a RAS blocker, either AC inhibitor, ARB, or diuretic to the maximal tolerated dose. Encountering a patient with resistant hypertension, the first step is to rule out pseudo-resistance that ensures that you have measured the blood pressure correct, you have excluded white coat hypertension, you have ensured treatment adherence. After that, you work up for secondary causes of treatable hypertension and look at the extent of end organ damage. Then, as per the algorithm, go for a stepwise addition of drugs, which should include a mineralocorticoid receptor antagonist, a chlorthalidone or a thiazide diuretic, followed by beta blockers, centrally acting sympatholytic agents, and vasodilators. And when all these pharmacotherapies fail to give us some answer, renal denervation therapy or vagal and afferent blockage is going to be a promise for future. So I'll conclude there. Thank you for your hearing, and I thank Shabir once again for giving me this opportunity, and I'm sure it's a testimonial for our 22-year camaraderie, and I hope to be a part of this next year as well. And I congratulate him to continue his perseverance of continuing his academic dissemination despite all these tough times that we are going to. And I conclude with a moment of prayer for all the suffering souls in this time of COVID and natural calamities. Thank you. Thank you all.
Thank you, Dr. Arun Gopi, for that enlightening lecture. I think an important point which you mentioned was the addition of the mineralocorticoid receptor antagonist. Very often it is an underrated drug in the management of hypertension. Maybe in patients with heart failure, it is given routinely, but in patients without heart failure, just for point. Any questions from the other members? One last question to you, Dr. Arun Gopi. I would just like to ask your opinion about home BP monitoring and ambulatory blood.
Yeah, this
in resistant hypertension or the pseudo-resistant hypertension.
I would say that there needs to be more wider use of home blood pressure monitoring and ambulatory blood pressure monitoring, not only in the field of resistant hypertension, but also in the management of routine hypertension, because a lot of the mismanagement happens because we are relying totally on clinic blood pressure reading. And we all know from trials that the end organ damage or the morbidity of hypertension comes from poorly controlled blood pressure readings, which correlate more with the home blood pressure readings or readings on the ambulatory blood pressure monitoring. They are more definitive than the clinic blood pressure reading, and they should become a part of the evaluation algorithm for all patients with hypertension.
Hello, Dr. Arun. Hello.
Yes.
You said, is it true that beta blockers come only in the fourth or fifth list as an antihypertensive in Indian patients also? Because we are having many patients with increased sympathetic activity with a resting heart rate of more than 80. Do you think we can start with beta blockers in these patients, especially younger patients?
Thank you, sir. That was a wonderful question. Again, a sought after question. See, we should understand that beta blockers were disrepute as an antihypertensive based on some from meta-analysis from Mersalis group, which actually enrolled maximum trials which had atenolol. And the reason why it went to disrepute was atenolol did not reduce the central aortic pressure sufficient enough to reduce the risk of stroke. But that's not true for all class of beta blockers. We have ample evidence of beta blocker as an antihypertensive agent, as you said, in young hypertensives with a basal heart rate which is more than 80 beats per minute. In young hypertensives, even if you look at the NICE guidelines, they say if the age is less than 55, it is A or B. That is, if the agents are either a RAS blocker or a beta blocker. In all patients with young hypertension, the major driving factor is increased sympathetic drive, as evidenced by a elevated resting heart rate. And in these patients, cardioselective beta blockers, especially bisoprolol and metoprolol, forms a very important treatment arm for these patients. So beta blockers are not in the dustbin as an antihypertensive. It's only that you should carefully use them for young hypertensives and hypertensives with compelling indication like presence of coexistent coronary artery disease or coexistent heart failure.
Thank you, Dr. Arun Gopi. I think we can move into the next session.
Thank you, Dr. Prashant. Now we will go. Now we will go to the next topic. The speaker of the next topic is a well-known person. Dr. Matthew John needs no introduction to an audience who are interested in diabetic management. Dr. Matthew John is an endocrinologist and at Providence Endocrine and Diabetic Specialty Center, Trivandrum. He did it MDM from the prestigious KEM Medical College, Mumbai. He had over 40 publications in index journals and is a well sought after speaker in many conferences. He is an investigator in phase 3 clinical trials in many clinical trials. He is a good organizer, as evidenced by he was an organizing secretary of Hcq in 2017. Over to you, sir. Dr. Matthew John,
yeah,
you can start the presentation.
Am I visible, CB sir?
Yes. And presentation also visible.
Yeah, thank you very much, Dr. Shabir, for this opportunity. I'm very thankful that Dr. Shabir is inviting me every year for this program. So I'll be looking at diabetic kidney disease, new targets and new therapies. So just to start off, diabetic kidney disease is the question, because it's very variably defined by different organizations. Basically, diabetic kidney disease is a chronic kidney disease which is attributable to diabetes. It is defined as an estimated GFR less than 60 or a urinary albumin creatinine ratio 30. So, to be this definition is that it is defined by a eGFR criteria and also by an albumin criteria. So both criteria are defined either or. That's it. We use diabetic nephropathy almost interchangeably with diabetic kidney disease. But there are some people who believe that diabetic nephropathy is a histological diagnosis. And non-diabetic renal disease may be present in diabetes patients. This have to be differentiated. Yesterday there was a talk, so I'm not going into those details. Having some problem in moving my slides. Yeah, thank you. If you look at the natural history of diabetic kidney disease, you can see how this progresses. You can see first there is an increase in albuminuria for most patients, which later progresses on to a proteinuria. And at the same time, you can see how eGFR behaves. The eGFR, what you can see on the picture is the yellow line, which initially increases. There's a stage of hyperfiltration. And later, the eGFR slowly starts coming down, and which moves on gradually year after disease progression. I have some problem with moving my slides. This is how it goes. Now, why do you want to, which is very frequently asked. So this is, there are, in this picture, what you would see is two lines. One is the gray line and one is the black line. So if you identify diabetic kidney disease early, what you can do is to institute treatment, which includes various treatment modalities, which I'll be describing, in addition to control of glycemia and control of hypertension. And if you take care of diabetic renal disease well early, you can see you are able to add around 10 years of life, extra life to the patient, or rather 10 years of dialysis-free life to the patient. So that is the importance of going for identifying kidney disease early in the course of the continuum and instituting treatment. Now, how do you diagnose diabetic kidney disease? I think this is something which does not require much of explanation, but just to give you normal values, the normal protein excretion is around 40 to 80 milligram per day, and the normal urinary albumin excretion is less than 20 milligram per day. And most of the albumin which gets excreted, most of the proteins which gets excreted will include the albumin, the TAM host protein comes from the tubules, and other proteins which is around 15 to 20% of the total excretion. So when the albumin excretion goes more than 30 milligram per day, or the protein excretion crosses 150 milligram per day, we call it that there is significant or abnormal proteinuria. A urinary albumin excretion of 30 to 300 milligram per called microalbuminuria previously, and it is now called moderately increased proteinuria. And in 100 milligram per day is called severely increased proteinuria or overt proteinuria. So these are the two terminologies that we use. What we do in outpatient is we have almost during the 24-hour urine protein and albumin. Rather, what we do is something called UACR or PCR. UACR stands for urine albumin creatinine ratio, and PCR stands for protein creatinine ratio. So you can see the normal ranges which I have mentioned on the sides. Calculate is a very important part of looking at renal disease, because if you had realized the graph which I showed you earlier, you can see that when you plot EGFR against the time, that is how you realize the renal progression. Because if you are plotting creatinine against time, you realize the very, very minimal changes in creatinine which may not be realized as the time and the age of the patient progresses. So these EGFR calculators are freely available on the net, and if you are not into the practice of using EGFR, please start using it, because that will guide you in diabetes choice of antibiotics, the dose of antibiotics, and many other things that you do in clinical practice. Now, once you calculate the EGFR and once you calculate the urine albumin creatinine ratio, then stage the CKD and put the patient in a particular staging. So that is very important, because that will decide what treatment you are going to give to that particular patient. So suppose you have a albumin creatinine ratio of say 30 to 300 milligram per day. Here what you can see is milligram per millimole in the picture, but this stands for 30 to 300 milligram per day. And your EGFR is between 45 to 59, you become stage G3A, A2. So you can always keep this picture in your outpatient department and stage your patients accordingly. Now, how do you get the disease under control? What are the interventions that are effective? So when you have normal albuminuria, your main intervention is glycemia and hypertension. When you have microalbuminuria, your main intervention will still continue to be glycemic control and hypertension, but that is the time to consider using ACE inhibitor, ARB, or the newer drugs like SGLT2 inhibitors. And one proteinuria, again, controlling hyperglycemia and hypertension is important, but all the more important that you uptitrate your ACE inhibitors, ARBs, and always consider use of SGLT2 inhibitors. Now, how does the natural history of diabetic kidney disease behave? So if you look at UKPDS, I put up the UKPDS data because this is the one data which has started following your patients very early in the course of disease and over a long period of time in a sort of randomized controlled setting. So 2% of patients every year progress from normo to microalbuminuria and from micro to macroalbuminuria. And at the end of 15 years, 40% had albuminuria and 30% had EGFR less than 60 ml per minute or doubling of serum creatinine. And 60% of those developing kidney function impairment did not have albuminuria, remember that, and 50% never developed albuminuria during the course of study. So this is to just tell you that you should be aware of an entity called non-albuminuric renal dysfunction in people with diabetes. And this is increasingly seen nowadays that we are using extensively ACE inhibitor ARBs for hypertension control. So patients don't go into the proteinuric stage. Now, coming to the treatment aspects, very important that with a lot of new molecules in place, we should not ignore the importance of controlling hyperglycemia. You can see in the first picture on the left, the red box, conventional therapy versus intensive therapy in patients with microalbuminuria. You can see that intensive therapy definitely reduced the number of patients who develop microalbuminuria in the UK Pds study. So this is basically a primary prevention of microalbuminuria. And on the right side, what you can see is the systolic blood pressure plotted against number of patients having doubling of serum creatinine or ESRT. Again, you can see that people who are well controlled in terms of the blood pressure less than 135, in fact, had a significantly lower progression of renal dysfunction. So both for albuminuria and for progression of EGFR, hyperglycemic management and blood pressure management are very important points. Now come to the role of RAS inhibition. These are two data just to show you how irbesartan, the first one is the IDNT study, the irbesartan trial, and on the right is the renal trial. Just to show you that compared to amlodipine, means irbesartan versus amlodipine, the first trial, and the renal trial, losartan versus the rest in terms of standard BP control versus losartan based BP control, you can see that the percentage of patients with ESRD or the patients of primary endpoint, the patients in the IDNT, both these places you can see that there is a reduction of risk with the use of ACE inhibitor or ARB. So after glycemic control and hypertension control, use of ACE inhibitor of ARB to maximum tolerated or maximum doses is a very, very valuable thing. Now, our knowledge of how drugs behave, the SGLT2 behaves, comes from the EMPOWERAGE outcome study, the CANVA, and the DECLARE-TME in terms of the SGLT2 inhibitors. So although the EMPOWERAGE outcome study was not a trial which is primarily done to renal benefits, there was a significant number of patients in the renal group who had problems, and you can see or worsening nephropathy, new onset macroalbuminuria, doubling of serum creatinine, and first initiation of dialysis. Everything went down significantly with the use of empagliflozin. Now, if you realize this, ACE inhibitor use was found in 80% of these patients. Around 11% of patients had microalbuminuria as macro, and 28% had microalbumin. So you have around 30% of patients in the cohort who had sub-CKD. Now coming to the canvas, again similar data, almost no difference. UACR reduced, albuminuria reduced, regression to albuminuria was more, regression from albuminuria to normal albuminuria was more in the people who were on canagliflozin, and the composite endpoint also reduced in canagliflozin. Here again, you can see ACE inhibitor use is around 80%, and overall CKD is around 20%. Similar data with the DECLARE-TME, which used dapagliflozin, again showing that all the renal composite endpoints reduced in patients who were using dapagliflozin in the DECLARE-TME. So, but overall CKD is only around 8%. So, among the three trials of SGLT2 inhibitors, CVOTs of SGLT2 inhibitors, you can see that 30%, 20%, and around 8% patients had CKD, sizable population. But remember that all these trials were reasonably low patients with renal dysfunction which were enrolled. You can see from the mean EGFR anything more than 70 and the UACR almost less than 20. That is the mean value. So these are all low risk. Now the Credence trial comes in. These are the real renal patients that you can see. People with EGFR between 30 to 90, UACR between 300 to 5,000. And on stable maximum tolerated dose of ACE inhibitor or ARBs. You can see that the group of patients getting 30% of patients had significant renal dysfunction between 30 to 40. You can see the rest of the distribution here. 4,000 odd patients were tried. So the results are really astounding, or rather fascinating. I should say the primary outcomes you can see significantly in favor of canagliflozin. Zeros in the p-values if you value p-values. You can see end-stage renal disease of serum creatinine or renal death significantly reduced. Dialysis, kidney transplantation or renal death significantly reduced. Not only was there in terms of renal, you can see the effects in terms of CV death or hospitalization for heart failure, major cardiovascular events, CV deaths, everything in favor of canagliflozin. So this is again to put forward a point that even in patients with renal disease, the end cause of death is cardiovascular, and SGLT2 inhibitors are wonderful in terms of looking at both cardiovascular and the renal outcomes in patients with diabetic kidney disease. Now it's important to realize that all these trials did in fact use SGLT2 inhibitors along with RAS inhibitors, and they have a significant synergistic effect RAS inhibitor and SGLT2 inhibitor. And I'm not going to explain each of this, but this is a wonderful sort of mechanistic picture which will help you understand how they act. So before I end my talk, the last 2-3 slides. So how do you go around for every patient? Glycemic control, control blood pressures, control the lipids, stop smoking. Start patients on inhibitor or ARB if they have albuminuria of any size, and that is titrated to the maximum possible dose without hyperkalemia. Then you continue to look at whether albuminuria is persisting. If there is albuminuria persisting, you consider use of SGLT2 inhibitors. So if you have patients who don't tolerate ACE inhibitor ARB, you can still go to use control blood pressure well, start using SGLT2 inhibitors. And the question which is often asked is that, does other drugs affect the efficacy of SGLT2 inhibitors? In fact, it doesn't affect. This is the data from the EMPOWER outcome study. You can see the last column on the right, that whether you are using ACE inhibitor or ARBs, whether you're using diuretics, whether you're using CCBs or NSAID, the effects of SGLT2 inhibitors still continue to persist in terms of renal outcomes. Now, after the Credence, there's a label change for canagliflozin which should be realized, that everyone diabetic kidney disease and albuminuria is a candidate with more than 300 milligram per gram of albumin is a candidate for the use of canagliflozin. So this is irrespective of your HbA1c, and the dose to be used is 100 milligram. If you top of that, you could increase the dose to 300 milligram. Otherwise, 100 milligram becomes the effective dose in most patients for canagliflozin. When I say new drugs, there are a lot of new drugs. We know that SGLT2, just like SGLT2 inhibitors, GLP-1RA has got a favorable effect on renal disease progression. So that is being studied. You have various other drugs, CCR2 antagonist, CCL2 antagonist, JAK1 antagonist, phosphodiesterase inhibitors. So various things in the pipeline. Allopurinol was once considered, but the Pearl trial which has put it down. So this is end of my talk. Thank you very much.
Thank you, Dr. Matthew, for that excellent presentation. Any question from the audience? Matthew, to start with, you said there is an entity called non-albuminuric renal dysfunction.
Yeah.
In the presence of that, is there any possibility of considering SGLT2 inhibitors as the first line treatment in diabetic patient ahead of metformin even? Hello?
Yes, we can hear you.
Hello, Matthew, can you hear me?
Hello, Dr. Matthew.
I think Matthew John has muted him.
Yes, it shows some, it shows some internet issue there.
Hello. Hello.
Hello.
Yeah. Can I?
And there is some issue with Dr.
Dr. Sabir, can we move ahead with the next session?
Yeah, we will go to the next.
I think we are not able to connect to Matthew John because of technical issues.
Yeah, Sibi sir can move to the next session, please.
Yeah, we can go to the next.
Yeah.
Over to Dr. Prasad.
Okay.
Yeah, mute.
So we will move on to the next session. I will introduce the next speaker, who is none other than Dr. Pds Shah, who is a vibrant diabetologist and the director of IVA Diabetes Care Center, Mumbai. He is honorary diabetologist at SL Raheja Fortis Hospital, Mumbai, and he also has diabetes care centers at Malad and Andheri. He is also a visiting faculty for the Fellowship of Diabetology at Dr. D.Y. Patil Medical College, Navi Mumbai. He is the founder and treasurer of the United Diabetes Forum and the organizer, scientific committee and faculty of CDI 2014 till date. So I hand over the session to you, Dr. Tejas.
Thank you very much. Big thank you to Dr. Full meeting. Just share my content. Audible and the slides can be seen?
Yeah, perfect.
Okay. So thank you very much. Yes, we are talking. I'm going to talk to you today about primarily two important drugs and their use in diabetes. What we know is cardiovascular disease is an important cause for morbidity and mortality, as you know, all over the world. Patients with diabetes are at an increased risk of cardiovascular disease. Prevention of any disease, as you know, requires intervention which needs to be done at a population level, as well as intervention which needs to be done at an individual level. So for cardiovascular disease, primarily, if you're talking about intervention at a population level, it requires lifestyle modification, education programs, etc. But at an individual level, we need to target the risk factors. We need to target therapies, particularly which would prevent the progression of diseases. In terms of cardiovascular disease, it would be drugs like aspirin, so statin, or management of lipids per se. So cardiovascular events are increased from 2 to 4 folds in diabetes. We know that in diabetic patients more than 65 years, almost 68% of deaths are due to coronary heart diseases. There have been enough studies to show that low dose aspirin per se is effective in reducing cardiovascular morbidity and mortality, especially for secondary prevention. But the question keeps on raising primarily its effectiveness in primary prevention. The prevalence of heart disease ranges from 2 to 4% in general population to as high as 55% among patients with diabetes. And almost 25% of the patients with an acute myocardial infarction have diabetes, which has been seen in various studies. Excess risk for cardiovascular diseases can be found in patients with type 1 and type 2 diabetes and pre-diabetes. And overall, the mortality rate for heart disease is almost twice in men and almost 3 to 4 times in women with diabetes. So there have been various causes which are responsible for these changes that we see in patients with diabetes. It could be the hyperglycemia, it could be the hyperinsulinemia, there's the autonomic neuropathy creeping in with duration of diabetes increasing, that is hypertension, dyslipidemia, obesity, smoking, altered metabolism in patients with diabetes, more incidences of cardiomyopathies and heart failures being there in the patients with diabetes getting diagnosed late, underutilized evidence-based therapies, which all could be responsible for increased vascular risk, primarily in patients with diabetes. Pathophysiologic bases for these increased diseases are many. It could be endothelial dysfunction, the arterial stiffness, the inflammatory changes, the oxidative stress in patients with diabetes, the dyslipidemia, hypercoagulation. Apart from that, lifestyle factors, inactivity, poor diet, obesity, all these things together lead to this problems of diabetes with cardiovascular diseases together. So in way back in 97, as the ADA had recommended aspirin as the primary and secondary prevention for cardiovascular events mainly. But over the period of time, various studies which have been done, studies did show benefits of with aspirin in patients with pre-existing cardiovascular disease and diabetes. There have been some primary prevention trials also done in patients without diabetes also, which showed an improvement, like the HOT trial, the APT, the early diabetic retinopathy studies, which had limited number of patients with diabetes. Duration of study was more than 5 years and showed an 18% risk reduction in patients for non-fatal MI. The physician health study showed almost a 44% risk reduction. But these studies had patients with diabetes in a very, very small amount. The population content for patients with diabetes were less, and there was not enough data to make sure that patients with diabetes for primary prevention really benefited with aspirin here. There have been again theories about the platelet changes that happen in patients with diabetes. Platelet phenotype changes, platelet variation is there. Chronic hyperglycemia leads to non-enzymatic glycation of glycoproteins. There is deficient insulin action or insulin resistance leading to platelet dysfunction. There is impaired response to prostaglandin. And there is other abnormalities like platelet turnover and endothelial dysfunction, which could be there in patients with diabetes. Response to aspirin is again thought to be different in these people. Aspirin, as you know, primarily is working to the inactivation of the COX-1 pathway, and due to the irreversible inactivation of COX-1, the antithrombotic effect of aspirin also lasts for an entire lifespan of platelets. So low dose aspirin sometimes does not show the adequate effect in patients here because the COX-2 pathway is not purely inhibited, and the changes happen through the COX-2 pathway also. And therefore, this question keeps on coming whether the effect of aspirin is equally good for primary prevention in patients with diabetes or it is only for secondary prevention. There are a few studies which have thrown light on this in the last few years. If you look at the Ascent trial mainly, Ascent trial was the largest trial done with around 15,000 patients almost, which addresses the question of benefits of aspirin. It used low dose aspirin of 100 milligrams and patients were followed up for almost 7 years, where the primary endpoint was to look at primary endpoint was looking at the marker incidence of infarction, stroke, and TIA. At the endpoint, mainly, it did show a difference of around 8.6% versus 9.3% in patients with aspirin. But overall, there was a 50% risk of major bleeding happening in patients on aspirin here, and for more than 40% of the bleeding occurred in the patient in the GI tract. So the benefit risk profile of low dose aspirin in the Ascent trial was independent of the baseline vascular events, but it was thought that the benefits did not outweigh the risk of bleeding per se. There was another paper which came out in 2007 from the ADA again, recommending that aspirin therapy should be used as a primary prevention strategy in those with diabetes at an increased CV risk, including patients more than 40 years of age with risk factors. But again, following that, there have been few important trials like the JPET trial, that is the Japanese primary prevention study. Again, it was a large study done. It looked at aspirin mainly in patients for primary prevention. Few patients had some risk factors here. The patients were followed up for almost 4 years, and the primary endpoint did not show benefit with aspirin in this subset of patients. The only advantage it showed was in patients above 65 years of age, but not in overall study population. The POPADAT study, which is again a comparative multi-center randomized trial, it looked at 1,276 Scottish adults more than 40 years of age, and it had patients with peripheral vascular disease. Those with the ankle brachial index of less than 0.9 were included, and the combination of aspirin and antioxidants were looked at in these patients, whether they give benefit. And the endpoint, again, it did not show a benefit for primary prevention in this subset of patients. And the hazard ratio and the incidence of events were almost similar in patients on aspirin versus patients who were not given aspirin. So these important studies did not show the additional effect of low dose aspirin, mainly for prevention of CV events. The current guidelines and consensus regarding aspirin are mainly stratified according to the risk of the patient, where a low risk patient is somebody uh, who has an incidence of risk less than 10%. A moderate risk is somebody with a risk with two risk factors and a 10-year risk of 10 to 20%. And a high risk individual is somebody with more than 20% risk with multiple risk factors again. So ESC guidelines in 2019 recommends that in patients with diabetes at a very high risk, aspirin of 75 to 100 milligrams per day may be considered in primary prevention in absence of contraindications. In patients with diabetes at a moderate severe risk, aspirin for primary prevention is not recommended. When low dose aspirin is used, a proton pump inhibitor should be considered mainly to prevent GI bleeding. And aspirin 75 to 100 milligrams may be considered in patients with a history of MI or revascularization, but with a definite evidence of cardiovascular disease on imaging. The ADA-EHA guidelines in 2019 again recommends that aspirin therapy at 75 to 162 may be considered as a prevention strategy in those with diabetes who are at an increased risk after discussing with the patient regarding the risk of bleeding. Well, the AHA in 2019 recommended aspirin to be used at a lower dose for primary prevention of ASCVD for adults between 40 to 70 years of age at a higher ASCVD risk, but should not be at an increased risk of bleeding. Coming to the second important therapy, that is statins in diabetes now. Well, what has changed in the last few years, if you look at the statin guidelines and the statin from 2016 to 19, there have been enough evidences that showed that lowering of LDL cholesterol is the primary factor to reduce cardiovascular events. There is no lower limit of LDL cholesterol reduction. The lower you go is better now, and trials have shown that there is no J-shaped effect for LDL cholesterol again. And statins have primarily proved that they are the drugs which are necessary to reduce this LDL cholesterol and in general to reduce the LDL atheroma accumulation. 6 important lipids which we know: the triglycerides, the VLDL, IDL, LDL, HDL, and FOB. And typically, the diabetic patients usually have a decreased HDL and an increased level of LDL and triglycerides, which we see. In terms of statin therapy, we have come a long way from the earlier statins. Gradually, we have now come on to more of atorva and rosuvastatin, which are the more safer statins, as we know. They differ in terms of their lipophilic and hydrophilic properties. Some of these statins, per se, the mechanism of action, as you know, is primarily through reversible inhibition of HMG-CoA reductase. They prevent the HMG-CoA reductase conversion here and thereby decrease the LDL, the cholesterol, and cause increased expression of LDL receptors. They're known to have various pleiotropic benefits also apart from the reduction of cholesterol. They're responsible for some amount of platelet activation, endothelial function improvement, macrophages. They have reduced the inflammation. They have effect on collagens, they effect on endothelial progenitor cells, and these pleiotropic benefits are also supposed to play a role in their primarily reduction of cardiovascular events. Prescribe statin or no is a question that comes up sometimes, which is really a question we are not be asking, especially in patients with diabetes. But the question came up because primarily due to certain factors. Way back in when the Jupiter trial came out, this question came out because they found out an increased incidences of diabetes happening in patients who are subjected to rosuvastatin in the Jupiter trial. There was almost a 26% increased incidence of diabetes. But later on, it was seen that with various trials which have been done with statins to find out the risk of diabetes, that the benefits far outweigh the risk that is there associated with it. This is one of the meta-analysis which was done, which looked at various trials and associating the risk of diabetes and statin. In this meta-analysis, almost there were 9 studies which were enrolled here, and there was a small increased risk of diabetes or relative risk of 1.13, which was seen here. Another meta-analysis was done with 13 important large trials. It included the VOSCOPS and the Jupiter also, and it showed an increased incidence of around 9 to 13% for patients with who have diabetes again. This was another paper in JAMA which said that statin therapy is associated with an increased risk of development of diabetes, but the risk is in terms of absolute terms, and definitely the benefits that statin gives in terms of cardiovascular risk reduction are far more superior. And what was seen in the various meta-analysis and the trials that a patient, 255 patients need to be treated for a period of 4 years to have one case of diabetes, and therefore the benefit, that reduction in cardiovascular risk that a statin gives should be should be considered, and not the risk of developing diabetes. 2020 guidelines for the patients with diabetes regarding statin mentions that for patients with diabetes 40 to 75 years of age with a cardiovascular disease, without a cardiovascular disease, a moderate intensity statin should be used. For patients with diabetes 20 to 40 years of age with additional atherosclerotic disease, in the statin therapy should be initiated. In patients with diabetes at a higher risk, and especially those with multiple risk factors between 50 to 70 years of age, a high intensity statin is necessary. And those with a 10-year risk, 20% or higher, if the patient's LDL target of less than 55 is not achieved or is still at 70, an additional drug like an ezetimibe should be added. For the second prevention strategies, for all patients of all ages, higher therapy should be added, and for patients who do not tolerate intended insulin, the maximum tolerated dose should be used. There are some important studies which have been done for primary prevention studies in patients with diabetes, like CARDS, ASPEN, HPS, which all showed a significant improvement. The ASPEN did not show, but the other two studies showed almost a 37 and 33% reduction in patients with diabetes. There is the patient studies like MEGA, ASCOT, and ALHAT, which again were done, which had subsequent of almost 20 to 25% of the subjects with diabetes, which showed some improvement. The PRO-YT mainly compared a higher dose atorvastatin 80 milligrams versus pravastatin and showed a 25% risk reduction in the acute coronary events in patients with diabetes again. So, in overall, if you summarize, statins should be used more cautiously in patients who are at lower risk. In groups in which the benefits of statins on CV risk reduction is the cautious use of statin is advised. If the statins are used in these low risk groups, restricting their use to those with a least moderate LDL elevation and regular monitoring of fasting glucose seems reasonable. The use of statins should not be withheld from subjects at a higher cardiovascular risk, even if they are prone to new onset diabetes, because their benefits outweigh their risk. And if new onset diabetes develops, statin treatment should not be stopped, but a switch to a more favorable statin should be considered here. So, balancing the cardiovascular benefit of a low dose aspirin or prevention and the bleeding risk must be considered. To examine the risk-benefit ratio of aspirin used for primary prevention in adults with diabetes, when low-dose aspirin use, a proton pump inhibitor should be advised. For primary prevention, aspirin should not be routinely used in individuals with type 2 diabetes, but should be considered with statins in significant reduction in cardiovascular events, and higher statins per se reduce the non-fatal events in people with established cardiovascular disease, and statins should be considered for all people with diabetes more than 40 years of age. Thank you very much.
Thank you, Dr. Tejas, for that wonderful lecture. Again, it was very elaborative. I have all the aspects of using aspirin and statins in patients with diabetes. So the message is very clear. Aspirin has to be given in most patients with diabetes for secondary prevention, and you have to individualize the patients for primary prevention of aspirin. Statin has to be given irrespective of to almost all patients with diabetes, over 40 years, and in less than 40 years, again, we have to stratify using multiple risk factors. Are there any doubts? Any of you would like to comment? Or else we will move on to the next.
Hello.
Yeah.
Is there any entity called aspirin resistance, and is it more common in diabetic patients? If so, should we go to other antiplatelet drugs in diabetic patients?
Yes, there is something called aspirin resistance. They have found out that there are some occasions where patients with diabetes do not respond to aspirin in the same manner, and there have been some exact theories for that are yet not known. there have been, and for such patients, of course, you should be thinking about switching over to other antiplatelet agents like clopidogrel is what is recommended.
Thank you.
End this session and hand over to the next moderator. I would like to thank Dr. Sabir again for giving this wonderful opportunity in Diabetes Today 2020. And I think we will move forward to the next session. Over to the moderator for the next.
Thank you, Dr. Prashant. We will go to the next session. Sabir, is it okay?
Oh, 1 second, sir. 1 second. We will invite you.
Thank you, doctors, for the wonderful presentation. So moving on to our next session, inflammation and diabetes. Let me welcome Dr. CBNS, Professor of Medicine, Medical College, Trivandrum, and Dr. Sabir Rashid, Organizing Chairman, Diabetes Today 2020. Over to you.
Yes, sir. You can start, sir. Please.
We will go on to the next session. Very interesting topics are there. The first speaker is Dr. Aravind Jagadish. He will be discussing about inflammation and diabetes, the missing link. Inflammation is being linked with many non-infectious conditions like diabetes, coronary artery disease, and all those things. Now we will listen to Dr. Aravind Jagadish, who is a speaker in various national and international forums. He is a senior consultant diabetologist, Dr. Aravind Diabetic Center, Bangalore. He is the president of the Karnataka chapter of the prestigious RSSDI. He was bestowed with Bangalore's highest civilian award. He is a winner of Times Healthcare Excellency Award also. Over to you, sir. Dr. Aravind Jagadish.
Thank you, Dr. Sati, for the nice words. I'll share my content. Are you able to see my slides?
Yes, sir. Yes, sir. Perfect.
Okay. First of all, good morning, everybody. Thanks, Dr. Sabir, for inviting me for this wonderfully organized virtual conference. However, we always love to come to Trivandrum, but this time because of this corona pandemic, so this is a well-organized virtual conference. Congratulations for that. Today, my topic is on inflammation and type 2 diabetes, a unique connection. So as we all know, so we have like ominous octet, that is 8 reasons for the pathophysiology of diabetes. And as the days going on, we are coming to know more and more of diabetes. I'm sure in coming days, it will be dirty dozen. Means 12 reasons for the pathogenesis of diabetes. So one of the important reason is diabetes is considered to be considered as an inflammatory disease as well. So today this session will discuss about this inflammatory aspect of diabetes. Me, Faraz, and Dr. Unni will be discussing about the 3 important topics about diabetes and inflammation. First of all, greetings from Bangalore. If you take inflammation, I'll go through the basics, certain aspects of basics of inflammation, so that this it should be a revision for all of us. So it is a part of complex inflammation is a part of complex biological response of body tissues to harmful stimuli such as pathogens, damaged cells, or irritants, and is a protective response involving immune cells, blood vessels, and molecular mediators. We all know the features of inflammation are heat, pain, redness, swelling, and loss of function. This is what we learned in our basic MBBS days. So what is the difference between acute versus chronic inflammation? You can see acute, what causes it. Acute inflammation like antigens such as bacteria, virus, trauma. Chronic inflammation is the unresolved acute inflammation. Continued presence of the antigen causes the chronic inflammation. What cells are involved in the response to the causative agents like polymorphonuclears, mononuclear cells, macrophages? Chronic inflammation, monocytes, macrophages, lymphocytes, and plasma cells. What mediators are released from that causes the signs and symptoms of inflammation? In acute inflammation, it is the vasoactive amines like histamine, bradykinin. In chronic inflammation, it is the cytokines, growth factors, ROS, and hydrolytic enzyme. When does this inflammatory response first appear? In acute inflammation, it is an immediate onset. In the chronic, it is a delayed onset. How long does this response last? Several days. In acute inflammation, chronic inflammation, it lasts long time, like it is months to years. So after the response, what happens to the tissue? Healing occurs once the inflammation is resolved. And in chronic inflammation, it leads to tissue destruction. I'm sure all of you know about this. Just a recollection of our knowledge. Chronic inflammation, principal link to cardiometabolic disorder. If you see, they take this inflammation, it is involved in so many diseases like atherosclerosis, metabolic syndrome, pre-diabetes, as well as diabetes. So what happens in chronic inflammation? What is the molecular mechanisms? You can see this, all the TNF alpha, interleukin 1 beta, PF, TGF beta, PKC, arachidonic acid, all leads to the activation of endosomal NADPH oxidase, leading on to ROS generation and activation of NAFKB, leading on to inflammation. This eventually leads to the development of atherosclerosis, diabetes, and metabolic syndrome. That is where the inflammation plays a role in the pathogenesis of diabetes. If you see earlier, this slide, earlier onset of type 2 diabetes in Indians. If you see this two studies, that is CURE study and NUDS study, in Indians, we are seeing a type 2 diabetes onset a bit early compared to Caucasian. This is what this study says. So I'm sure most of you all seeing in your city that diabetes is coming, type 2 diabetes especially, is coming at an age of 25 years. In my city, in Bangalore, it is more of software engineers are there because of a lot of stress and a lot of junk foods and all those things are happening. We are seeing a type 2 diabetes at an younger age group around 25 to 30 years. The predilection of type 2 diabetes among Indians, you see Asian Indians, 2 to 3-fold higher prevalence of insulin resistance compared to ethnic groups. Diabetes develops at an younger age in Indians, that is at least a decade or two earlier than the European. This is the most worrying things for our Indians. We have to seriously address this issue from doctor level as well as the government level. We have to address these issues. Migrant Indians have much higher prevalence of CAD and CAD mortality rates compared to the host population in US. Indians develop CAD at least a decade earlier. So all this is an important aspect to be considered in our patients. This is the famous Professor Yagnik's chart. That is a thin fat Indian. So thin fat Indian, low BMI and high central obesity. You can see the Professor Yagnik sitting with the Caucasian. Both of their body mass index was 22.3. But if you see, Professor Agnik's body fat was 21.2% compared to the Caucasian, that is 9.1%. What does it say? The Indians are leanly, what do you say, is slimly obese, thinly obese. You can say it as they are thin, but still they are obese because of the visceral adiposities. That is the fat accumulation in all the major organs. This is the one of the reasons for insulin resistance, and this is the one of the reasons for the early development of type 2 diabetes and cardiovascular disease. So this is a beautifully depicted slide. Says that metabolic changes in the Indian phenotype. You can see on the left hand side that the European phenotype. The A is the length and B is the lean mass, that is the metabolic capacity, and C is the volume of the fat mass, what you can see. On the left hand side, you can see the European phenotype, and on the right hand side, you can see the Indian phenotype. You can make out the difference that Indian phenotype, the volume of fat mass is more when compared to the European phenotype. So what happens over a period of time, this thin fat phenotype goes on increasing in Indians. The fat mass goes on accumulating, and the elevated ratio of load to capacity and ultimately leads to the development of diabetes. Central obesity and consequent inflammation drives insulin resistance in Indians. You can visceral adipose tissue is a seat of chronic low-grade inflammation. Camerin and adipokine initiates the inflammation by recruiting plasmacytoid dendritic cells into the visceral adipose tissue. This induces the production of type 1 interferons, pro-inflammatory polarization of adipose resident macrophages, ultimately leading to adipose tissue and systemic insulin resistance, leading to more type 2 diabetes. So if you see the obesity phenotype, an interesting slide, you can see on the left hand side the normal weight, where the BMI is 18.5 to 25. You can see the fat mass is normal, lean mass is normal, cardiorespiratory fitness is also normal. The second person you can see is an athlete. His body mass index is more than 30. Fat mass is decreased, lean mass is increased, cardiorespiratory fitness is increased. Third one is non-sarcopenic obese. Body mass index is more than 30. Fat mass and lean mass is increased. And there is a cardiorespiratory fitness. There is a mild impairment. The last one, you see the sarcopenic obese. His fat mass is increased. Lean mass is decreased. And cardiorespiratory fitness, there is a severe impairment. See the various phenotype of obesity which you are seeing in the picture. I'm sure you're wondering where majority of obese Indians will fall. We are the mixture of all of them. Not all obese patients are equal. So on the left hand side, you can see there is a metabolically healthy obesity defined by increased adiposity, body mass index, insulin sensitivity, and systemic inflammation will be neutral. Adipose tissue, there is distribution. There is an increased subcutaneous distribution of fat compared to intra-abdominal fat. And adipokines will be like decreased adiponectin, increased leptin, increased resistin, increased FGF21. On the right hand side, you can see metabolically unhealthy obesity is defined by increased obesity, adiposity, and body mass index, decreased insulin sensitivity, increased systemic inflammation, and metabolic syndrome will be present. Adipose distribution, there is an increased subcutaneous as well as intra-abdominal fat, which leads to increased epicardial fat, increased hepatic fat, increasing the skeletal muscle fat, increased pancreatic fat. Wherever all the fat accumulation will be there. And then coming to the adipokines, there will be a grossly decreased adiponectin, increased leptin, increased resistin, increased cytokine, and FGF21. This is all metabolically unhealthy obese patients. So this is a simple chart saying that inflammation contributes to insulin resistance, beta cell dysfunction on the onset of type 2 diabetes. You can see on the left hand side, whenever there is a high metabolic load, that is excess calorie intake, there goes to adipose tissue, there will be adipocyte hypertrophy, hyperplasia, dysfunction, adiposity inflammation leading on to insulin resistance, leading on to type 2 diabetes. On the right hand side, you can see what happens in pancreatic beta cells. There will be endothelial stress, oxidative stress, mitochondrial dysfunction, reduced insulin secretion, leading on to islet inflammation and dysfunction, leading on to insulin sufficiency and type 2 diabetes. This is how the pathophysiology of inflammation is contributed in the development of type 2 diabetes. Very simple chart, but very easy to understand. So this is how the metabolic stress acts on the beta cell and causes the secretory failure and apoptosis, leading on to interleukin 1 beta macrophages plays a role, and this is how the islet inflammation takes place in type 2 diabetes. Inflammation in microvascular complications of diabetes. On the left-hand side, you can see on the adiposity, adipocytes and vasculature, cytokines and chemokines. Ultimately, what will happen is leading on to pro-inflammatory and pro-atherogenic mediators, which will eventually lead on to insulin resistance and leading on to the development of atherosclerotic plaque. So inflammation in microvascular complication, once again, the hyperglycemia and hyperlipidemia leads to oxidative stress, leads to inflammatory signaling cascades, local activation of pro-inflammatory cytokines, leading on to inflammation, finally resulting in nephropathy, retinopathy, and neuropathy. So inflammation is the main thing to be considered in the development of microvascular as well as macrovascular complications of diabetes. What are the potential markers of the chronic low-grade inflammation? First one is the basic one, that is the WBC count, and serum cytokine markers, that is interleukin 6, TNF alpha, interleukin 10, acute phase reactants like hsCRP, amyloid A protein, fibrinogen, and CD8 plus T cells increased and decrease in the CD4 plus T cells. This is all the potential inflammatory low markers in the chronic low-grade inflammation. WBC count and hsCRP, which can be used in our day-to-day practice, is the basic and very simple to do it. There are various studies which says about the prospective evidence linking the inflammatory markers to the diabetes development. It may be starting from 2001 from Pradhan et al. There are so many studies which you can see in the chart where they have seen the inflammatory markers like CRP, interleukin 6, fibrinogen, white cell count, adiponectin, all have been implicated in the development of type 2 diabetes. So adiponectin, TNF alpha, and inflammatory cytokines and risk of diabetes. If you see the systemic review and meta-analysis, we can see that low levels of adiponectin is increased the risk of type 2 diabetes. So adipocytokine biomarkers are the predictors of type 2 diabetes and should probably be measured to target therapy and intervention. Tomorrow, if somebody asks, Doctor, inflammation you are telling so much, is there any biomarkers to say whether future I'll develop a diabetes or not? So at that point of time, you can definitely measure this interleukin level, adipocytokines and all those things and tell this is high. So you have to address this issue so that we can prevent the development of type 2 diabetes. So CRP is an independent predictor of risk factor for the development of diabetes in the West of Scotland coronary prevention study. You can see this highest quintile associated with more than threefold risk of developing diabetes. hsCRP and incidence of type 2 diabetes among patients without diabetes, increasing the tertiles of hsCRP at baseline associated with an increased risk of type 2 developing diabetes during a median follow-up of a period of 3.7 years. So this is a study which is depicting, if you see the mediators of inflammation in progression of normal to type 2 diabetes in Indians, you can see this on the left hand side, you can see the serum hsCRP, on the right hand side you can see the interleukin 6. So both are elevated in hyperglycemia. So these are the important things to be considered, hsCRP and serum interleukin 6. So you see the hsCRP and the CV risk marker in diabetes. On the left-hand side, you can see that both of them are increased, and that will have a predictor of development of cardiovascular events. So many studies have been done using the hsCRP as an biomarker. So hsCRP, CV risk factor with or without metabolic syndrome. This is also based on the Women's Health Study and the West of Scotland coronary prevention study. You can see that how the hsCRP plays an important role in the development of metabolic syndrome as well as type 2 diabetes. Associations between the basic indicators of inflammation and the metabolic disturbances, you can see here, higher the hsCRP, higher the risk of development of type 2 diabetes as well as cardiovascular disease. And another one, high blood cell count is associated with a worsening of insulin sensitivity and predicts the development of type 2 diabetes. This is the study published in 2002. So since nearly 20 years or 25 years, this concept is going on about the inflammation and diabetes. So baseline WBC count more than 6,900 had an independent 52% risk in diabetes risk versus the lowest quintile, that is the WBC count of 5,000, less than 5,400. Associated between the basic indicators of inflammation and metabolic disturbances, you can see WBC count more than 9,000 have an higher risk of developing developing type 2 diabetes. These are the three things you can see relationship between the WBC, CRP, the metabolic syndrome, being both a Caucasian and the African Americans, which has showed that the concept of metabolic syndrome is high in these patients and ultimately leading on to the development of type 2 diabetes. Adiponectin and progression to diabetes in the DPP, that is the Diabetes Prevention Program. You can see if baseline adiponectin level are higher, progression to type 2 diabetes is slower. So that is the importance of adiponectin. Another perspective studies in diabetes, it shows neutralizing TNF alpha at the earlier stages improves the insulin sensitivity. See this study, which was published way back in 1994. That means the concept of inflammation and diabetes is going on since 1994. So, type 2 diabetes, an inflammatory disease leading to insulin resistance and beta cell function. These are the international evidence starting from in 2001 in JAMA. You can see the CRP, interleukin-6 and risk of developing type 2 diabetes. In 2004 also, there was a link between insulin resistance, obesity and diabetes. 2011, type 2 diabetes as an inflammatory disease published in Nature's. In 2013, a chronic inflammation role in the Obesity Diabetes Association, a case cohort study. So various studies has been done to show an inflammatory link to the type 2 diabetes. Ladies and gentlemen, to conclude my talk, prevalence of type 2 diabetes is rising in India. Markers of systemic inflammation has been critically implicated in the pathogenesis and complications of type 2 diabetes. Abundant clinical evidence explains role of systemic inflammation in obesity, metabolic syndrome, insulin resistance, and beta cell function. Thank you for your patience hearing. Over to Dr. Unni and Dr. Faraz. To the end of the session, we can have a good discussion.
Thank you very much, sir, for the excellent presentation. Sabir, we will go to the next topic or we will take questions now?
So then we will have the discussion at the end.
Okay, thank you.
So I think we anyway congrats Dr. Aravinda for that excellent lecture. Next topic is something regarding inflammation again. The topic is the role of hydroxychloroquine in diabetes management in the present scenario. For this, we have a guest speaker. He is my very close friend, Dr. Faraz Parisha. He is the professor, Medicity Institute of Medical Sciences, and also the director of FS Endocrinology and Diabetes Center. He is also the senior consultant endocrinologist, Tumbe Hospital. He is a principal investigator for various global trials, and he has been awarded the prestigious Abdul Kalam Memorial Award in the field of endocrinology. He has more than 50 national and international publications. He has articles in more than 50 national and international indexed journals, and he is also the speaker for various national and international forums. Over to you, Dr. Faraz. Okay, it's okay.
Yeah, so I hope my screen is visible.
Yes, perfect.
Yeah, so thank you so much for inviting me for this academic feast, and then thank you, Arvind, for rolling on the dice. To continue it from there, as my friend was talking about inflammation, I think in this corona epidemic, one thing which everybody wanted to speak about is about their opinion. You would agree, right? From a layman to the politicians, everybody has tried to share their opinion. And I'm so thankful that we did not follow this gentleman's advice of injecting something for treating the pandemic. So this is how things are rolling out in this pandemic on the lighter side. So I think Hcq is now crossed lot number of geographies. You will see now it's being used across the globe, at least for the pandemic what we are having. So definitely it is wise to know about the history as well. So first time US FDA approved way back in 1950s for predominant use in rheumatoid arthritis and lupus. 2001 it was endorsed to used in rheumatoid arthritis. 2006 for polymorphic light eruptions. 2008 for lupus erythematosus, and 2014 is where the Central Drug Standard Control Organization in India gave it a clean go for usage in diabetes. So in 28 July, DCGI approved for the first time use of Hcq in type 2 diabetes. It said that Hcq can be used as an adjunct to diet and exercise to improve glycemic control of patients who are not controlled on metformin and sulfonylurea combination. So there are different various mechanisms of action of Hcq. Still, I would not say I would place my hand on any of the four, but there are different mechanisms which are being postulated. So out of the four, the inhibition of insulin degradation, reduction in inflammation, improves insulin sensitivity, and beta cell preservation. So we'll see one by one. So inhibition of insulin degradation. We all know that insulin degradation pathway half-life of insulin is 4 to 6 minutes, and then it gets degraded by the insulin degrading enzymes in the acidic environment. So how does Hcq, what does Hcq does? So Hcq, insulin binds to a receptor on the cell membrane. We have seen that there is internalization of the receptor insulin complex in the vesicle. Then the insulin dissociates from its receptor. This is where again Hcq is trying to act. And it is also acting at the acidic environment. So Hcq is causing alkalization, results in inactivation of the IDs, which lead to less insulin degradation, so that insulin is released as it is and ready to act again. So this is one pathophysiology which is behind the action of Hcq on reducing diabetes. And then this is an interesting paper which says that Hcq increases insulin levels. There is definitely preclinical evidence. So as blood Hcq concentration increases, the insulin degradation decreases and blood insulin level rises. This is seen as early as after 10 days of therapy. Coming to the inflammation, I think my fellow colleague has spoken already a lot on inflammation and role of CRP. So this is one drug which is definitely has shown that it reduces hsCRP by more than 1 when correlating with reduction with the A1C. So it is not only helping to reduce the hsCRP, but it is also correlating to the reduction in A1C, which can be seen in the range of 0.7 to 1.3 in patients who were treated with insulin, glimepiride, and metformin on whom the Hcq was added. It improves the insulin sensitivity. So this is again very, very important. I think it is clearly showing that it has anti-diabetogenic effects on insulin sensitivity and beta cell function. So Hcq improves the beta cell function and insulin sensitivity in non-diabetic patients. So this was a random double-blind non-diabetic overweight patients who had impaired fasting glucose between 100 to 126. They were started on 400 milligram on one arm versus placebo on another arm for a period of 13 weeks. So this results have shown that Hcq improves both the beta cell function and insulin sensitivity in the pre-diabetic individuals as well. the metabolic effects may explain why Hcq is associated with lower risk of type 2 diabetes. So there was a conclusion that Hcq increases the plasma adiponectin levels, and we all know adiponectin levels is higher in females when you compare it with the males. It is lower in diabetic patients when you compare it with the non-diabetic patients. And adiponectin is definitely, the higher the level of adiponectin, the lower amount of insulin resistance you will have. So this is one drug which has shown that Hcq improves the adiponectin level, possibly being a mediator of favorable effect on glucose metabolism. Hcq improves the insulin sensitivity in obese non-diabetic individuals. So this is a clinical pharmacodynamic study where Hcq increases the insulin sensitivity during the first 6 weeks. So you will see on the left side of the graph, the first 6 weeks, the insulin sensitivity when the patient was on Hcq raised from 4.5 to 8.9. And then there was a dip when Hcq was stopped. Similarly, Hcq decreased the insulin resistance. So when Hcq was started, the insulin resistance dipped from 2.1 to 1.8 in 6 weeks. And again, it took a peak when Hcq was stopped. So this is a study which was done in rat to see the Hcq hindering of diabetic ileopathy, and then it carried its signature on the inflammatory cytokines. So 45 rats were divided equally into two groups, one with diabetes and one with Hcq on diabetes. So the rats who were on Hcq and diabetes, these groups showed preservation of islet of Langerhans structure, slight increase in the beta cell mass, and then IOL proliferation and neogenesis. And then it has definitely shown to reduce the amount of inflammation. I think this is where we all would agree. That is why the role of Hcq came drastically in treating the present pandemic of COVID, because there is definitely some amount of inflammation reduction which is happening with this drug, because all of us know that yes, COVID is also now a inflammatory disease. So just to correlate it with diabetes, what my friend was saying, diabetes, one of the pathophysiological mechanisms, yes, we have moved on from 8 to Arrhenius 11 and to the dirty dozen 12, we will move till there. So there is definitely a role of Hcq in reduction in the inflammatory parameters as well. So it has a lot number of international studies, Indian studies, observational studies, and case reports. I'll be talking only about the few of them. So this is a study which was published in JAMA in 2007, where probability of developing diabetes in rheumatoid arthritis patients with Hcq use was seen. So this is a prospective multi-center observational study of 4,000 odd patients with rheumatoid arthritis who had taken Hcq and 3,900 odd patients who had never taken Hcq. And there was no diagnosis or treatment of diabetes in outpatient university-based and community-based rheumatology practices with 21.5 years of follow-up. So that's a huge follow-up. So use of Hcq for more than 4 years was associated with 77% lower risk of developing diabetes in patients who were on Hcq who had rheumatoid arthritis when you compare it with their other colleagues. This is an international study in 2018. This is a randomized double-blind placebo-controlled trial of Hcq versus placebo. The patients who were included in the study had A1C of more than 8, were having obesity, diabetes for more than 1 year, were on metformin 1.5 grams and glimepiride inadequately controlled. So the third line of agent, Hcq 400 once daily, was added in one arm compared to placebo, which was added in another arm for 24 weeks. So there was a significant improvement. You would see the graphs there, not only in the fasting, which was reduced by 60, postprandial, which was reduced by 135 milligrams, and A1C by 1.3% when you compare it with the placebo. So definitely there was a drastic reduction in fasting, postprandial, and A1C when Hcq was added as a third line agent when patients were not getting control on metformin and sulfonylurea. This is a head-to-head comparison study of Hcq versus pioglitazone as third line of agent. So here again, patients who were inadequately controlled had an A1C of 7.5 to 11 with metformin and sulfonylurea were taken into the study. One arm Hcq was started, another arm pioglitazone was started. So again, this also endorses on the point that Hcq may be beneficial in uncontrolled type 2 diabetic patients as a third line agent. This is the first Indian clinical trial, the efficacy and safety of Hcq in treatment of type 2 diabetes. A blinded randomized compare again with pioglitazone. So 806 patients were assessed for eligibility. They were type 2 diabetic patients, again uncontrolled on two drug combination therapy, metformin with glimepiride or metformin with gliclazide at their maximum doses. A1C of between 7.5 to 13%. Out of which total patients in the run-in period were around 493, out of which 267 patients were randomized, one arm on Hcq and one arm on pioglitazone. So there is hardly anything to choose when you see the results at baseline and at 24 weeks. So you'll see at 24 weeks, the fasting blood sugar reduction with Hcq was 19.87 milligrams when you compare with pioglitazone, which was around 20. Similarly, you will see this results in postprandial, and A1C reduction with Hcq was 0.87% when you compare it with the pioglitazone arm, which was around 0.9%. So there was definitely indication that this is non-inferior as a third line drug when you add instead of pioglitazone. So Hcq in type 2 diabetes observational studies where around 49 patients were included in this study. Again, type 2 diabetic patients on combination of two oral hypoglycemic agents, metformin and sulfonylureas, not getting controlled, A1C of more than 7.5%, were started on Hcq 400 milligrams once daily for 24 weeks. So the interesting part is none of the patients discontinued the drug during the course of treatment owing to these side effects. I think this is also helping us and telling us that yes, the only side effect which we have already seen with this drug is some amount of nausea or some abdominal discomfort, which we have seen usage of chloroquine or hydroxychloroquine way years and years when we have treated patients with malaria with these drugs. So to come to my last slide of my presentation, Hcq and type 2 diabetes observational studies. This is a real life effectiveness and tolerability of Hcq in diabetes. So definitely this is one drug which is not only helping us to reduce the sugars, but it has definitely shown some reduction in metabolic parameters like lipid profile. It has shown reduction in LDL also. And then the patient did not have any side effects because of which they had discontinued the therapy. So just to end it on a lighter note, I think all of us sitting here have seen Sholay, or all of us have heard stories about Sholay from our parents, from our grandparents. If Sholay would have been remade in 2020, if I think my senior colleagues who are sitting here would remember the famous line where mother used to say to the children, "So ja, varna gabbar aa jayega." I think if it was to be remade, it would have been changed to, "जब बच्चा बाहर से आता है, तब माँ कहती है, हाथ धो लो वरना कोरोना वायरस आ जाएगा." So be safe, stay safe, and stay healthy. Thank you so much.
Thank you, Dr. Faraz, for that wonderful lecture. Thank you, Dr. Faraz. I think, and a special thanks to keep time also. So we will have the discussion at the end. So I think, Sibi sir, you can continue.
Now we will go on to the next topic. Real world evidence of role of hydroxychloroquine in diabetes mellitus. I am privileged to introduce Dr. A.J. Unnikrishnan. If I go on to narrate the credentials of Unnikrishna, it will take all the time for this entire CME. So I will just introduce him. He is a senior consultant endocrinologist and CEO of Chellaram Institute of Diabetes, Pune, which is an IDF certified center. Has published the largest multi-center study of subjects with pancreatitis and pancreatic diabetes worldwide. He is a former editor-in-chief and founder-editor of the Journal of Thyroid Research and Practice. He is the executive editor of Indian Journal of Endocrinology and Metabolism. He has more than 160 publications in Indian index journals in favor of his credits. He has received the Subhash Mukherjee Oration Award for the Endocrine Society of India. Also received the Srivastava Award from the RSSDA. He is an awardee of Jacob Memorial Prize for the Best Patient Care awarded by the CMC Vellore. He is a fellow of the RSSDA, and he also received recently the Diabetes Excellence Award at Digital Diabetes Summit at Hyderabad in 2019. Over to you, sir.
A pleasure being here. Thank you, Dr. Sabir Rashid, for a wonderful meeting. And thank you, Dr. Sibi, for the kind introduction. I hope I am audible and that my slides are visible.
Perfect, sir. Perfect. Please carry on.
Okay. Thank you. And I'm going to talk about hydroxychloroquine in the real world. And let me begin with a. Now, this is a 56-year-old lady with type 2 diabetes since 2011. She also has rheumatoid arthritis. And she had been on Ayurvedic treatment for rheumatoid arthritis. Initially, when we saw her, her fasting glucose and postprandial glucose were high and the glimepiride dose was increased. Finally, the sugar wasn't coming down. And because of the rheumatoid arthritis also, I added hydroxychloroquine to the regimen. So as you can see, she was on glimepiride, sitagliptin, metformin, to which I added hydroxychloroquine. This was long time back in 2017, where my initial experience of hydroxychloroquine was with rheumatoid arthritis patients with diabetes. And then, after 24 days, the fasting blood glucose came down from 170 to 135, and the postprandial came down from 201 to 191. And she said that she felt much better in terms of her joint pain. Into perspective, because I'm going to talk about the real world experience with hydroxychloroquine. This is a prospective investigator driven study. So I'm looking at cases and then I'm pulling out some data which backs the use of these cases in practice. So this is a real world study of type 2 diabetes, an observational study which looked at 250 subjects with diabetes more than 5 years. Now you can see the people in this study were already on metformin, taking glimepiride, were taking pioglitazone and sitagliptin. 100% of these people taking all these drugs: metformin, glimepiride, pioglitazone, sitagliptin. A small proportion were taking canagliflozin, empagliflozin, dapagliflozin, and voglibus. So in this group of patients, probably these patients were not keen on insulin. So the authors gave hydroxychloroquine, and you can see the HbA1c came down from 8.8 to 6.4. The fasting plasma glucose by 58%. And this is another real-world study which showed that in a small number, the LDL reduced and the fasting plasma glucose reduced. One of the worries about hydroxychloroquine is its effect on the retina, and I must disclose that I am an investigator for trials and present trials and upcoming trials on hydroxychloroquine. So this is one of our with hydroxychloroquine. Patient was started on linagliptin, glimepiride, metformin. Patient was on amlodipine and lisinopril, and in May 2019, hydroxychloroquine was added. It's important that you can see that with hydroxychloroquine, 70 years old, 4% to 6.1%, But it's very important that these people actually be screened for retinopathy. And in people on retinopathy, hydroxychloroquine ideally should not be given, though the trial is in progress. But I think the worries of retinopathy with hydroxychloroquine are largely exaggerated because while yes, it can cause retinopathy, the risk of retinopathy is only with very high doses given for a prolonged period of may not make a difference. But you still have to do annual screening, and you can see the annual screening. As part of the annual screening, optical coherence tomography was done for this patient, which shows that everything was okay. So again, to tell you, this is a study of the safety and effectiveness of hydroxychloroquine in management of people with type 2 diabetes. I must add that these slides have been made by me, and this assessed the real-life safety and efficacy of hydroxychloroquine in 95 subjects. Type 2 diabetes. These subjects had hydroxychloroquine started, and then they were assessed again. The diabetes duration was 9 years, and statins and antihypertensives were used. This data was just published as an abstract, and you see the data. This was by Chawla et al. In Diabetes 2020 at the American Diabetes Association. You can see that within just a short period of time, at 3 months, the HbA1c came down from 8.8 to 8%, and subsequently at the end of 6 months, it came down to 7.7%. The fasting plasma glucose was 185, came down to 150. Postprandial was 228, came down to 188. Of course, no safety signals were seen in the study, and you can see the lipid profile also improved. So here is a study which compares hydroxychloroquine versus teneligliptin. And this is a 6-month study, and you can see that from baseline, hydroxy in terms of fasting, 173 and 171. And at 6 months, these values come down to 128 and 132. Again, the postprandial was 268, 266, and that came down to 190 and 190. So this study shows that in terms of glucose control. Here is another study where hydroxychloroquine was added. And you can see fasting coming down well. This was again a study of 105 type 2 diabetes patients, age 56 years, BMI 2600 people completed the study. People were on already high dose gliclazide of 80, not very high dose, but high dose, and metformin 1000 milligrams, and glargine at or more than or equal to 30 units, coming down to 6.69 at the end of 6 months. And you can see the postprandial coming down in the orange color, the fasting coming down in the blue color. And this study shows that hydroxychloroquine works in a background of insulin, sulfonylurea, and metformin. This is another gentleman, and you can see that he was taking sitagliptin, metformin, lispromix, dapagliflozin, and hydroxychloroquine. He did not wish to take basal bolus insulin therapy. What we found in this gentleman who had a AGP done is that his estimated A1C was 5.8%. This is also now called a glucose monitoring indicator. His glucose was 121, so very good control. You can even see the time in target was 72%. Below target was 21%. The recommended time in target is 70%, so that's in range. But you can see this patient has significant hypoglycemia, and hypoglycemia is probably because of insulin. And in this patient, ideally, insulin could be reduced or even stopped in some of these patients. But just to show you that sometimes we have to individualize our practice and use the best treatment that is needed. And in this gentleman, a group of all these drugs were able to control the blood glucose levels. So I'd like to just summarize some of these observational studies. So you can see that if you just take, there are studies which compare teneligliptin, vildagliptin, and sitagliptin, and all these studies show there is a good HbA1c reduction with hydroxychloroquine, but in addition, there is a CRP reduction in the hydroxychloroquine group. But it all reported that if you look at metformin and sulfonylurea and compare it, supposing your patient is on metformin and SU or you add hydroxychloroquine, you will get a similar result. So mean hydroxychloroquine HbA1c was 6.5 in the hydroxychloroquine group versus 6.8% in the metformin group and 6.7% in the uptitrated glimepiride group. So if your patient is on a median dose of glimepiride and metformin, you have two options. One is you can increase the dose of glimepiride metformin. Second is you can add hydroxychloroquine. So adding hydroxychloroquine in this study showed a good effect on the HbA1c. And another study which looked at very interesting 200 versus 400 dose, and this study showed that 400 was better than 200 dose. The HbA1c reduction, fasting plasma glucose, postprandial plasma glucose were all better in the 400 dose compared to the 200 dose. Also, there are studies which show that hydroxychloroquine may be as good as teneligliptin or sitagliptin. If you want to summarize these other two studies, which looked at hydroxychloroquine as an add-on to metformin, SU, and basal insulin, what it showed is that the fasting, postprandial, and HbA1c all improved with hydroxychloroquine. Insulin glargine dose came down by where we gave a gliptin and SGLT2, metformin and Lyspromix, and when hydroxychloroquine was added, you can see the HbA1c coming down, and this means that insulin can actually be reduced. In 41%, the authors report that insulin glargine could be completely stopped. In 12%, they could reduce gliclazide to 40 mg. And of course, this study by Dr. Cha was presented by Dr. Farishta as well. And this was an abstract presented at the American Diabetes Association meeting, which showed that postprandial and HbA1c reduced by 18% and 0.8%, and there was a lipid benefit. Hydroxychloroquine is a promising third-line anti-diabetic drug in patients with type 2 diabetes who are uncontrolled on metformin and SU. Better glycemic control as compared to DPP-4 inhibitors was shown in some studies, but we can accept that glycemic control could be similar with hydroxychloroquine. There is some evidence of a beneficial effect in high insulin users because hydroxychloroquine may help to decrease the daily insulin dose. Hydroxychloroquine in clinical practice isn't associated with glycemia, and decrease in highly hsCRP, which is shown to be the main culprit in inflammation, was noted in hydroxychloroquine patients. So thank you all for listening to me. Thank you, Dr. Sabir, for a fully organized meeting, and it's back to the chairperson for the discussion.
Sibisa, please. Sibisa Ranna, okay.
Hello, am I audible?
Yes, sir, please.
Thank you, sir, for the nice presentation on the real-world evidence of Hcq in type 2 diabetes. Now we will take questions. Okay, Shabir? There are some questions in chat box.
Yes, sir. One question is there.
One Dr. Tyagarajan Arumugam wants to know what is the dosage of hydroxychloroquine and criteria for starting hydroxychloroquine in type 2 diabetes.
Would you like me to take that question?
Yeah, you can take, sir.
Thank you. And so therefore, hydroxychloroquine for diabetes, the Indian government has approved it for the 400 milligram dose. And what they have recommended is that it is an adjunct to treatment with metformin and sulfonylurea. So anybody on 2 oral drugs who are not getting a control of HbA1c, hydroxychloroquine could be considered. The only exception is it should be used in type 2 diabetes, and also it is better not to use the drug in people with pre-existing in people who fail type 2 diabetes, failing 2 drugs, having high HbA1c without retinopathy, that's where I think hydroxychloroquine at the dose of 400 milligram once a day can be used, and you can use it for a prolonged period of time, up to 3 or 4 years. As your patient is not very thin, below 50 mg, 400 mg will be a slightly higher dose. So as long as the patient is above 50 or 60 mg, the 400 mg dose should be quite good.
Thank you, sir. There is another question from Dr. Ajit Kumar Shetty. What about the patients with cardiac diseases and diabetes? Is there any increased risk of starting hydroxychloroquine with concerns of QT interval prolongation? And this is more important in the current situation of corona pandemic.
So hydroxychloroquine, maybe Dr. Farishta and Dr. Jagdish should also take this question. Has in rheumatoid arthritis trials, there have been large trials that actually showed that hydroxychloroquine reduces cardiovascular events. But indeed, if patient is already having a history of arrhythmia, or there is a predisposition to arrhythmia, or is using drugs capable of producing arrhythmia, then you need to be careful. But otherwise, hydroxychloroquine, you don't have to worry about this situation. But with regard to the COVID pandemic, and maybe my colleagues, Dr. Arvind and Dr. Farishta, could also opine on this.
So my opinion is like, especially if the patient is above 60 plus with the previous history of cardiovascular disease, if anything is there, always, if at all you plan to start hydroxychloroquine, it's better to take a simple ECG and just measure the QT interval, and accordingly you can plan. Otherwise, if you see the hydroxychloroquine various study, it has a beneficial role to play in cardiovascular outcome also. So because it's an anti-inflammatory, there are various studies to show that in a long run, if the patient is taking hydroxychloroquine, it can prevent the cardiovascular morbidity and mortality. So, but always it is better to get on, because in an young patient, definitely it's not a problem, because we are using as hydroxychloroquine is used in various conditions like rheumatoid arthritis, is maybe SLE, many conditions, and people are taking since many years without any problem. So, as Dr. Uni pointed out, always make sure that the 2 drugs, when they're using, for example, hydroxychloroquine and azithromycin, when they're used together, always monitor the QT interval. For us, any opinion yours?
I think I would agree with my senior colleague Dr. Uni and Arvinda on the same that yes, baseline ECG is always required if we are starting it in senior elderly patients with pre-existing cardiovascular disease. And then yes, it is very just to be on the safer side if we are starting in elderly individuals, as my friend said, azithromycin, sometimes even cimetidine. Of course, we are not using it now, but even quinolones are also prone for prolonging the QT intervals. So just to see if the other drugs, arrhythmogenic drugs, which can aggravate the effect of Hcq in pre-existing diabetic cardiovascular patient.
One important other thing is the role of hydroxychloroquine. If you take in this current situation, what I'm seeing is in a diabetic patients who are already on hydroxychloroquine as a 3rd line or a 4th line agent, we are seeing less number of COVID virus infection. It's totally, it may be long-term study is needed, but what in my clinical practice, in a day-to-day practice, those who are already on hydroxychloroquine for diabetes, there are less chances of coronavirus. And this is what the ICMR is also telling, to use hydroxychloroquine in a selected, in all patients, in fact. So many are agreeing, and even the Lancet publishers also, what they had published about the few bad things about hydroxychloroquine. Now they have reverted and they are telling that hydroxychloroquine is a better drug.
I think I would definitely Agree on the same because ICMR is now even indicated for doctors for pre-exposure prophylaxis as well. So they are recommending doctors to take it, or healthcare professionals who are on high risk of exposure. I think we all know the dose 800 milligram loading for it by 400 milligram. First they said weekly once for 7 weeks, and now they say you can take it for longer period of time. So definitely I would agree with my friend on my clinical experience as well. I would share my clinical experience with the healthcare professionals which have been taking my colleagues, my juniors, which have been taking. So that definitely there's been lesser incidents in healthcare professionals also who were on Hcq, and even if they had developed the symptoms, it was just very, very mild. None of them had that moderate or severe symptoms.
And hydroxychloroquine for retinopathy or something, the cumulative dosage is huge. Like it may be like 1 kg. I'm sure Dr. Unni will agree about this. In an overall duration of hydroxychloroquine intake, if the cumulative dosage is more than 1 kg or so, then the chances of retinopathy is there. So 400 milligram once a day is in a long term also, even after 5 years, 6 years, it should not be a big concern.
Agree.
Okay. Thank you, all the speakers, Dr. Aravinda, Dr. Faraz, and Dr. Unnikrishan for the excellent presentations and nice discussion. For want of time, there are lots of questions, but for want of time, we will conclude. We should conclude at this moment. And I should thank Dr. Sabir for the wonderful opportunity, and thanks Sabir and all the team. Thank you very much.
Thank you.
Thank you very
Thank
much.
you.
Thank you
Thank
so
you all
much.
the three respected faculties for the wonderful lecture. Thank you,
Thanks, Abhay.
co-chair also. Now moving on to the next session. Thank you.
Thank you very much.
So moving on to the next session, and inside it, but it has got two parts, and inside its part one will be chaired by Dr. Mohanan Nair, Senior Consultant Physician and Diabetologist from Trivandrum, and Dr. Sunil Prashop, Consultant Physician and Diabetologist, Government Medical College, Kollam. Over to you.
Morning. Am I audible? Am I audible?
Yes, perfect. Please.
Good morning, everyone, and welcome to the next session, which is termed Inside Edge. And we have three eminent speakers in this particular session. All of them are both nationally and internationally reputed academicians. And also I have my co-chair, Dr. Sunil Prashop, who is the most promising and upcoming academician in the diabetology and general medicine in Kerala as well as in India. And I'm very happy to introduce Dr. Srijithan Kumar. Actually, this session has three topics. One is very relevant topics. First is reversal of diabetes possible, and conducted by Dr. Srijithan Kumar. And second is on cholesterol, the good, bad, and the ugly, by Dr. Balachandran. And finally, the third session is going to be by Dr. Jyoti Dev, who is going to speak about the perils of non-evidence-based therapies in this particular COVID era. And moving on to the first session, Dr. Srijithan Kumar. The name of Srijithan Kumar is actually a household name in all the families of doctors. He is well known amongst all the doctors, not only in Kerala but in India, because he is a very, very leading figure in Indian Medical Association. He is currently the director and CEO of the Diabetes Care Center in Trivandrum, and he was the former president of Kerala State Branch of IMA, and he is holding very enviable positions in national IMA, and currently he is a member of the Central Working Committee, and he was the founder of the innovative patient care scheme in IMA, and he is also the chairman of the INDEC, that is IMA Network for Trauma and Emergency Care. And most important of all, he is the national chairman of IMA Medical Students Network, spearheading all the say the struggles that are going on the current issues in on medical fraternity and medical profession currently. And he was also also formerly a member of the Kerala Medical Council. And added to that, he is an ex-major in the Army Medical Corps. And over to my dear friend, Dr. Srijit.
Thank you very much, Mohan Nair, sir. It's indeed a great privilege, actually, to get introduced by my own elder brother. Yeah. Now, let me share the screen. Fine. Hope my screen is visible.
Yes, sir. Yes, sir. Perfect.
Yeah.
Please.
So thank you very much. And at the outset, let me thank Dr. Sabir for this very kind invitation. It's a great opportunity, and thank you very much for that.
Sir, your slides have been changed little.
Yeah, no problem. I'll share.
Fine, sir.
I wanted to see you also.
Okay.
Okay. Right. Now you can see?
Yes, sir. Yes, perfect.
Good enough. So over the next 15 minutes or so, let's talk about this concept of reversing diabetes. At the outset, I should tell you that this is not something new, and I had presented this maybe at least 2 or 3 times in the past 1 or 2 months. And for some of you, it may be a repetition, but what I plan to do today is to go a little slow and just touch upon the 4 or 5 important slides and take home this concept that yes, type 2 diabetes is reversible for those who care to reverse that. So in 450 years before Christ, Hippocrates told that food be thy medicine. And in 2017, this very famous trial, the direct study published by Mike Lean and Roy Taylor at the International Diabetes Federation, which was conducted in primary care, and they primarily targeted weight management. So they took nearly 300 patients, and half of them went in for the best drugs, and half of them went in for 800-calorie diet. And with this 800-calorie diet, they started bringing down the weight. And what they found was to look for a remission of diabetes, whereby they meant that the HbA1c should stay less than 6.5% without any drugs for at least 2 months. So that is what they called remission of diabetes. And this is what they got. So in those patients who achieved some weight loss, so that means in the intervention group, 46% overall did not require any drug for managing diabetes. And if they had lost more than 15 kilogram weight, then 86% of patients did not require any drug. So they told that remission of type 2 diabetes is a practical target for primary care. And this was a big revelation. And if patients had lost, we told that more than 15 kilo, 86% went into remission. More than between 10 and 15, 57 kilos. So put together, if a patient has lost more than 10 kilo, the chances of going in remission was around 73%. 73% of them did not require any drug. So they concluded that type 2 diabetes is a complication of weight gain and excess body fat, and it is not necessarily a permanent condition. I think that still we are a little slow to accept this very, very important fact that if people are going to maintain their normal weight, characterized by their normal waist, then the chances for diabetes itself disappears. And even if they have had the onset of diabetes, they can go back. So almost half with early type 2 diabetes can achieve remission. And this was, mind you, done in primary care settings. So this became hot news that type 2 diabetes is not for life, and that was in 2017. And then we started discussing this about remission. So what is actually remission? Is it that diabetes is permanently cured? No, it may not be. For some people, it may not ever return, but for few people, it may return. But one thing is for certain, and that it is possible. So if a A1C of less than 6.5 can be maintained for 1 year without any diabetes medication, it is called partial remission. If the A1C can be kept less than 6%, it's called complete remission. And if it can be maintained for more than 5 years, it's called prolonged remission. So by remission, it is not that we don't mean that it goes away for life. Maybe it is true for some people, they may not ever have it in their life. But for most people, at least for many years, we can postpone that. That is one thing. And second thing is that even for those people who need to take drugs, the dose can be drastically brought down. So there are a lot of medical benefits of diabetes remission. It removes the need for drug treatment for diabetes. It controls a lot of cardiovascular disease risk factors like blood pressure, lipids. All these get normalized, and there is a likely reduction of microvascular complications. But for that, logically, it sounds appropriate, because when the blood glucose go down, the microvascular complications go down. But for evidence, we'll have to wait, because this is a new approach. So how do you reverse diabetes, or how do you make remission possible? There are possibly three mechanisms. One is bariatric surgery, two is low-calorie diet, and three is carbohydrate restriction. So let me tell you that these two are different methods. There is one method which is carbohydrate restriction, like you don't count too much on calories, like what you do in, for example, in a keto diet. And then a low-calorie diet where you are actually bringing down the calories, and then bariatric surgery. So in a keto diet, for example, you are only restricting carbohydrates severely. You are not actually bothered about the total calorie consumption. Whereas in a low-calorie diet, you are bringing down any form of calorie, and bariatric surgery. So any of these three mechanisms can reverse diabetes, and you see that the effect is almost the same. If you use any of these mechanisms, you can see the reduction in A1C. Of course, reduction in weight is definitely much more with surgery than with lifestyle intervention. But reduction in A1C is the same, even if you do a surgery or you go for a dietary intervention. So that means that our dietary intervention is as effective as a bariatric surgery. And isn't that something very great? But then there are some people who argued that, okay, 2017 direct study got published, but maybe it is just a temporary phenomena, because we know that such things cannot sustain. So what happened then? They followed up these patients for the next 2 years. And in 2019, they published the 2-year follow-up study. And this is what they found. So initially, 46%, that means 68 of the initial 149 people had achieved remission in the first phase. And when they followed up for 2 years, they found that 53 of the 149, that means 36% of the original population, still remained in remission. And look here, even those patients who were not in remission, there was at least 50% reduction in the use of diabetes medication. So 1/3 with early type 2 diabetes achieved long-lasting remission was their conclusion, and they told that it's not type 2 diabetes is not necessarily a lifelong condition and is reversible by weight loss. Not only that, blood pressure, lipids, quality of life, adverse events, everything have a favorable outcome. And Mike Lean told why it happens. So he told in this famous editorial in Nature, he commented, type 2 diabetes, its dominant cause is weight gain with ectopic fat accumulation in vital organs. So that is very important. So fat accumulates in ectopic organs, most notably the liver and the pancreas. And this long-term weight loss maintenance, and this produces, and that is reflected by large waist circumference. So if someone has large waist circumference, it's not innocuous. It's an indicator that there is excess fat in his liver and pancreas, and that is causing type 2 diabetes. And if long-term weight loss maintenance is possible, then at least half of the patients can go in for remission. So now let's come to Indians. A waist of less than 90 centimeter in men and less than 80 centimeter in women is ideal. We know that our huge majority of our population, a recent study in Kerala had shown that up to 76% of women had abdominal obesity. And we think that, since everyone has that, maybe that is normal. No, that is not normal. And unless we start targeting that, there is no way we can reverse this epidemic, an exponential increase in diabetes and other lifestyle disorders. So we know that when the waist circumference increase, there is lipid accumulation in organs. I already told that: liver, pancreas, muscles, heart. Liver exports too much glucose and VLDL. Muscle fail to oxidize glucose. That means there is insulin resistance. Pancreas, first phase insulin response is lost. And all these lead to type 2 diabetes. And when fat accumulates, we know it's pro-inflammatory, pro-thrombotic, pro-insulin resistant. I'll not go into all these details. Now, see this, some people believe maybe it's true only for Westerners, not for Indians. No. 44% of diabetes and 23% of cardiovascular disease in India can be attributed to overweight and obesity. And even if the intra-abdominal fat is high, even if a person is non-obese. So look at that. So for Indians, still, obesity is one of the most important factors for type 2 diabetes and cardiovascular disease. And even if someone is not obese, the chance for intra-abdominal fat is high. So we know that it is pro-thrombotic, pro-inflammatory, produce a lot of cytokines and cause a lot of complications. And by reversing obesity, all these unfavorable factors can be brought down and diabetes can possibly be reversed. And diabetes reduce the risk of developing diabetes by nearly 60%, reduce the risk of blood pressure by nearly 66%, and heart attacks and stroke by nearly 60%. And it is not that it takes quite a long time to achieve that. No. Fasting plasma glucose can normalize within 7 days of a low-cal diet. And there is a 30% decrease in hepatic fat in the first 7 days. And that is probably sufficient to normalize the insulin sensitivity of liver. And in 8 weeks' time, the glucose-stimulated insulin secretion returned to normal in pancreatic fat content, fell over 8 weeks, and beta cell function improved. All this if the person can be given a very low-calorie diet. So storage of liver fat can occur only when the daily calorie intake exceeds expense. So that is why it is very important for us to tell our patients that how many calories you need a day. So irrespective of whether it comes from carbohydrate, protein, or fat, the first question that patients should be made aware is that how many calories they actually need a day, because if they are going to exceed that calorie, then fat is going to accumulate. And then sucrose is not good. Okay. So having known that type 2 diabetes is not for life, there are increasing global acceptance for that. So this is a statement by WHO. Energy restriction through a very low calorie diet can lead to the reduction of symptoms or even reversal of hyperglycemia typical of type 2 diabetes. They quoted a study from Barbados. I'll not go into the details. There are a lot of trials. Look ahead, then the Predimed, Direct we already discussed. And a lot of dietary interventions are gaining popularity. And this is a study from Netherlands. This is our own study where we showed that with 3 months adequate dietary intervention, 86% of our patients reduced some weight and 72% of our patients could either decrease or stop their medication. So that is a huge revolution coming from various approaches. And now if we don't go for this intense measure, let's see what will happen. Now, if we are going by the standard care, only 0.23% of patients will achieve remission. So the status quo approach will not reverse the health crisis of diabetes, and we have to think out of the box. We have fairly large evidence to tell that reversal is possible. And now let us see how it can be done. So first, we need to know that 2 things are very, very important for the human body. And the first thing is physical activity. Exercise is very important. I know that there was a detailed discussion yesterday, so I'll not go into the details. Suffice to say that without 30 to 45 minutes of aerobic exercise a day, any day is incomplete. So that's so much part of our physiology that 30 to 45 minutes of aerobic exercise every day is essential. Maybe we can add that with anaerobic exercises like strengthening exercise twice or thrice a week, or maybe even more, and flexibility exercises. But I think what is most important is the activity of are the activities of daily living. I'll just quote one example. If we sleep for 1 hour, we spend around 50 calories, 50 to 56. If we sit up, we spend around 70 to 78 calories. And if we just stand up for 1 hour, we spend nearly 125 calories. So that is why it is important to incorporate such healthy habits in our day-to-day life. That means instead of sitting and watching TV, someone should maybe walk and watch, or walk during telephone, take the stairs, and so on. So we should encourage our patients to do as much physical activity as possible and try to achieve 7 to 10% of weight loss. Now, when we talk about food, there is independent evidence that fruits, vegetables, and probably legume consumption is good. This is from the Pure study by Dr. Yusuf et al. And they told that there is a lower risk of non-cardiovascular and total mortality. So irrespective of the calories, irrespective of the carb content, high consumption of fruit, vegetables, and legumes per se are very beneficial. There are various types of eating pattern: Mediterranean diet, vegan diet, low-fat diet, low-carb diet, very low-carb diet. So, but let me just summarize in 2 lines. Reducing overall carbohydrate intake for individuals with diabetes has demonstrated most benefits. So, obviously, if you take more carbs, you will have more glucose. If you take less carb, you will have less glucose in your blood. It's as simple as that. So the best method to bring down the postprandial hyperglycemia is to reduce the carbohydrate intake in food and emphasize on non-starchy vegetable, minimize sugar, and choose whole food. Now, often people say that, okay, I asked my patient to diet, and probably he's doing a good diet also. He has lost some weight, but still, there is no remission. Why? This slide answers that. Now, there are 2 types of interventions: therapeutic intervention and subtherapeutic intervention. So, if a patient has to actually go in for remission, he has to reduce substantial weight. So, you see here, the weight loss in all the therapeutic studies where they could achieve an overall remission of nearly 50% was much higher compared to the weight reduction in subtherapeutic studies. So that means a patient should be encouraged to reduce at least 10 to 15 kilograms of weight, at least more than 10 kilogram of weight, if he has to achieve remission. Fine. Now, reduced carb means reduced blood glucose, and dietary fat is not considered to be as bad as what it was thought to be. So maybe we go a little liberal on that. And Jason Fung recently told that it is just not the energy intake and the energy output, but also the insulin levels which determine how the fat stores would be. So along with reducing energy intake and increasing energy input, we also need to keep the insulin levels low in our system if we are not to accumulate fat. And that can be achieved by maybe a very low carb diet and maybe methods like intermittent fasting. So we will follow what's very clear. So I think 2 things are most important. One, how many calories we need a day. And that is, if a person has to reduce his body fat, he should be put on 20 to 25 calories per kilogram per day. And for a normal weight person, maybe 30 calories per day. And the second question is, where should these calories come from? Maybe less than 50% should come from carbohydrates, and that's the most important statement. 20% from proteins and 30% from fat. The planetary food plate also tells that this is the global food plate. This is the conventional food plate, which says that fill half your plate with fruits and vegetables. The other half should be proteins and half should be grains, and 10% can be dairy products. So a healthy balanced diet means a lot of fruits, vegetables, whole grains, pulses, seafoods, and nuts. and to have less red meat, processed meat, sugary food, drinks, refined grains like white bread. So I'll summarize by saying that reversal of obesity can lead to reversal of diabetes, and reversal of obesity doesn't necessarily mean that the patient has to be huge. And when you reverse diabetes, when you reverse obesity, it is also important that the patient should be encouraged to achieve maximum weight loss, target at least more than 10 kilogram weight loss. Consumption of good food is essential because not only that it gets away with these diseases, a good food, especially consisting of lots of fruits, vegetables, can actually bring down the chance for cardiovascular risk also. And carbohydrates have to be limited. Fat concepts are changing. Remission of diabetes is possible, and it is high time that we move beyond the standard care to achieve remission. So there are many interventions coming up, and we also are trying to achieve that in our own little and humble ways. So thank you once again, Dr. Sabir, for this very kind opportunity. And I think I am left with 1 or 2 minutes in my 20-minute schedule. And maybe we'll take up questions now or later as whatever the chair pleases. Once again, thank you very much for this opportunity.
Thank you, Dr. Srijit. Am I audible?
Yes.
Am I audible? Thank you,
Yes,
Dr.
sir.
Srijit, for the wonderful presentation. And actually, it's a new concept, and I know how busy you are. Are you going to stay back till the end of this session, or are you leaving early? If you are leaving early, you can take questions right now.
Now, whatever you wish, Anna, I can't question your authority.
I know the sort of time pressure you are having. So if you are happy to be here for...
Better
No problem.
can stay back, sir.
I'll stay back.
Okay, sir. Thank you. Thank you.
Then Sunil, please introduce the next speaker and lead the session. Sunil, Dr. Sunil.
Okay. After that fantastic session by Srijit and Kumar sir, we'll move to the next topic. And the next topic is going to be dealt by a renowned physician and academician, Balachandran sir. He is from Dr. Nayer's Hospital, Kollam, and he is a very, very renowned academician. He is from Kollam, and he has been awarded the FICP, FACC, and so many degrees and fellowships. And he has been elevated to the Faculty of Medicine and Diabetology of Newcastle University, Australia, and he is a regular speaker in various diabetic forums also. Over to you, sir. And the topic sir going into deal is the cholesterol, good, bad, and ugly. Over to you, sir.
Am I audible?
Yeah.
Let me share the screen. Screen is okay?
Yes.
Yes, sir.
Okay. At the outset, let me thank Dr. Shabir, Dr. Deepa, Prashov, the organizers, and Dr. Mohan Nair and Prashov for chairing the session. And I am very unfortunate to being sandwiched between two renowned speakers. One is Srijit on one side and Jyoti Dev on the other side, and Ramachandran is going to follow. So my topic is on cholesterol. It's a very burning topic. What I'm going to, because we have been seeing a lot of, if I'm not audible, if the slide doesn't move, please inform me. Lot of WhatsApp and social media messages about cholesterol is good. You can eat any amount of fat. So my talk has nothing to do with the movie, famous movie acted by Clint Eastwood and Eli Wallach. So there is a report in Scientific American, don't stop worrying about cholesterol. And you can have unrestrained consumption of French fries and pizzas. And CNN said that cholesterol in food is not a concern. And he's a pro-cholesterol anti-statin lobby by Chris Kresser. Diet heart with cholesterol and saturated fatty acid are not the enemy. All these things happened after the book which was published, which is called as The Big Fat Surprise by Nina T. Cole. It was considered as one of the best books in 2014 by Forbes.com, Wall Street Journal, Economist, one of the 10 best book and best-selling books. You can download this book in Kindle and then read it and forget it. And this is the book which has changed the outlook of so many people, and people started eating, and they are not controlling the diet. And there's another person who is the protagonist of cholesterol and anti-statin campaign is the Mercola. You can go to the site and see many number of his papers. All these things, 40 trials to determine whether lowering cholesterol level can prevent heart disease. Australian Aboriginals have lowest cholesterol level, but the highest rate of heart disease. Cholesterol levels in the European countries, especially, was very high, but the death rate was low. So hence, cholesterol factor is of minor importance as a risk factor in cardiovascular disease. So that is it's the most important is the hypertension, obesity, diabetes, and insufficient physical activity. But all these things have been changed. They've been proved after the Interheart study, where definitely the cholesterol forms the major cardiovascular risk factor for myocardial infarction. So the 2015 US DA, that is Dietary Guideline Advisory Committee, came with cholesterol is not a nutrient of concern. Saturated fatty acid is not harmful. Eggs can be consumed in any amount. You can see that the DGA statement concluded there is an insufficient evidence to show the restricting dietary cholesterol lowers the low density lipoprotein. And cholesterol, saturated fatty acid is not a nutrient of concern for overconsumption. Hence, stop demonizing saturated fatty acid, because there is no significant evidence for concluding that dietary saturated fatty acid is associated with an increased risk of coronary artery disease. There are a lot of papers, thousands of papers in the literature, both peer-reviewed and non-peer-reviewed journals, and supporting cholesterol intake and eggs intake and saturated fatty acid intake. All of them, the proud sponsors are these three. And many more nutritional and food companies are also have conflicts of interest. So, but one thing you must understand, cholesterol is required by the body. Every animal cell produces cholesterol. Acetylcoenzyme A is converted to mevalonate and several steps and 20-odd steps and goes to by HMG-CoA reductase into cholesterol. It builds mammalian membrane fluidity, neurons, myelin sheaths, span cells, steroid hormone, fat-soluble vitamin, bile, antioxidant. So many dietary products contain cholesterol. But one thing we all must understand, the body produces 1,000 to 1,500 milligram of cholesterol. Whatever the body needs it produces, and it is recycled also. And the free cholesterol is present only in a very small amount. It is daily present as lipoprotein. The food cholesterol is different from blood cholesterol. Don't confuse fat with cholesterol. There are good fats, there are bad fats. When it's sitting on your plate, it is just a plain cholesterol. It becomes good or bad when it's packaged into particles called lipoprotein in your bloodstream. According to lipid hypothesis, since cholesterol is transported around the body inside the lipoprotein particles. The cholesterol, the conventional wisdom, when you estimate cholesterol, it indirectly tells you the estimation of LDL particles. So mostly about 80% to 85% of the people, possibly even low concentration of HDL. So both variations strongly associated. What is more important is the LDL particle numbers. So in the meta-analysis of over 60 trials, higher intake of saturated fatty acids were associated with the increased risk of LDL and decrease in triglyceride. Although saturated fatty acid increase LDL, many reduces the LDL particle numbers. And the Cochrane database said stroke, total MI, non-fatal MI are replacing saturated fatty acid with polyunsaturated fatty acid, reduces the coronary artery disease events by 14%. The fat it matters, the long chain fatty acid and short chain fatty acid, what the fat you take is more important. We all know about the various fatty acids and monounsaturated fatty acids. Metabolically, the best elevate HDL and lower LDL, olive, mustard, groundnut, and ginger. What is more harmful is the trans fatty acid, which produces various types of metabolic abnormality, as well as risk of Alzheimer's, cancer, obesity, etc. So in the omega fatty acid also you have N6 and N3. N6 is proatherogenic Prothrombotic, poor accident, whereas N3 is less atherogenic, less thrombotic, and less antioxidant activity. We know the saturated fatty acid and cholesterol is 87%. Whether it is good or not, it is harmful in excess in producing the atherogenesis. Whereas PUFA safflower oil, it is PUFA content is very high. So what the N6 N3 ratio is more important. Safflower oil has got a very high ratio. If anybody takes a sunflower oil or safflower oil, cornflower oil, only it is very harmful. So there is a need for mixture of the oils. What is more important is the amount of fat in our diet. We have what is called as invisible fat intake in different states. A lot of invisible fat, around 20% of our diet contains invisible fat. So you don't need to substitute fat at all in the diet. From excess fat, diabetes and coronary artery disease begin. From excess fat, diabetes and coronary artery disease die. So from 2015, we have come to 2020 dietary guidelines. We're a little more softer. It said that limit calories from added sugars and saturated fatty acid and reduce sodium intake. Take a better saturated fatty acid. The saturated fatty acid is non-harmful saturated fatty acid. That's it. So a fat-free, low-fat dairy product, including milk, yogurt, and cheese, and fortified soya beverages, healthy eating pattern is important. And reduce saturated fatty acid and trans fatty acid. That's a message by the 2020 guidelines. The American College of Cardiology and Heart Association came in 2013 stating that they were doesn't want to commit. They said that dietary cholesterol does not influence serum cholesterol, but excess is a nutrient of concern. Hence, the conventional wisdom says that dietary cholesterol increases the risk of heart disease and type 2 diabetes. Only herbivores get atherosclerosis. Man and human beings are herbivores. We have a different teeth. We have an appendages are different. Intestinal tract is long. Body cooling is by sweating. And all practical purpose, we human beings are herbivores. This man is the W.C. Roberts. He is the editor of the JACC for more than 10 years, president of the American College of Cardiology, staunch supporter of anti-cholesterol campaign, and did a lot of research on atherosclerosis. He said that atherosclerotic plaques are easily produced experimentally in herbivores. Cholesterol is present in experimentally produced atherosclerotic plaques in human beings. Societies and subjects with high serum cholesterol and LDL have higher frequency of atherosclerotic events. It is a 7-country study. He also said the only way to produce atherosclerosis is to feed them with high cholesterol and saturated fatty acid. No one has produced atherosclerosis by experimentally increasing high blood pressure, diabetes, or blowing smoke or stressing the animal. All the multifactorial origin, diabetes, smoking, obesity, secondary exercise of atherosclerosis is not acceptable when cholesterol level is less than 150 and LDL is less than 60. Even the inflammatory hypothesis is not acceptable. So you need a level of LDL cholesterol of plasma of 25 milligram would be sufficient to nourish the body cells. What you need is only 25 to 50 milligram of LDL to keep your requirement. You don't need more than that. So if you look at the neonates, they are only ranging from 15 to 30 milligram of cholesterol. So it is most important to the endothelium. Dysfunction is produced by smoking, hypertension, and diabetes. Even if lipid is bad, atherosclerosis won't occur if endothelium is good. People with normal lipid can still have atherosclerotic cardiovascular disease if endothelium is bad. We have seen plenty of people coming to us and asking me, sir, my cholesterol is low, my LDL is low. Why should I get a heart attack? Why did I get a heart attack? This definitely is endothelium is bad. More than 30 billion population data from various studies that high LDL causes MI, strokes, and death. Now that we have the Atherosclerotic Society consensus panel last year said that LDL causes atherosclerotic cardiovascular disease. There is absolutely no doubt about it. And they also went further and said that atherosclerosis will not develop if LDL is less than 50 milligram. And start rearing your children right from the younger age group to keep the LDL level around 50 to 60. Carbohydrate is a main culprit. Eat more fat and less carbohydrate, bring it to 45%. The risk of heart disease, every additional 100 milligram of dietary cholesterol, serum cholesterol increases roughly by 2 milligram. Consuming 1 to 3 eggs per day would increase LDL by 4 to 12 milligram per deciliter. We have cohort studies where 22% increased risk of all-cause mortality and 28% higher risk of heart failure people who eat more eggs. And in a study that tracked about 37,851 men, 80,882 women, and 14 years, they said that high incidence of coronary artery disease, 49% higher risk in women, and conceive more than one egg. And a physician health study, a women health study, all have proved that an eggs per week, 7 eggs per week, increase the risk of coronary artery disease. So they gave all the scientists to comment on the 2015 dietary guideline. They said that 2000 dietary guideline conclusion that dietary cholesterol is not a nutrient of concern, is not based on the best scientific evidence available. And the DGAC has misled the public to believe that a healthy dietary pattern could contain an unlimited quantity of eggs. So contrary to DGA's decision, AHA President 2017 said that there are a lot of media have going on and dietary cholesterol. He said that dietary cholesterol is very much a nutrient of concern because it increases the LDL, a well-established risk factor for coronary artery disease. This was published in American College of Cardiology, and the AHA president continued to say that weight of evidence that plant foods are better with low saturated fat. Coconut oil is 82% saturated fatty acid, and studies show it raises LDL bad cholesterol as much as butter. And American Heart Association and ACC does not like coconut oil. They recently published this year, Association of Dietary Cholesterol or Egg Consumption with the increased incidence of cardiovascular mortality, published in JAMA. And now the 2020 American Heart Association and ACC have come to a compromise stating that dietary cholesterol does increase low-density lipoprotein cholesterol. But saturated fatty acid is not that harmful, but it is better than the carbohydrate. Hence, they said that saturated fatty acid to the consumption is to be reduced, but choose the amount of type of saturated fatty acid. That is more important. In Indian real-world evidence that only 2.8% of the population having LDL less than 50 milligrams. So the PURE study, which was published last year, though it was not considered as a scientific study because it's mostly of a questionnaire-based study, and it was more than about nearly 135,000 population. As Dr. Srijit said, that fruit and vegetable legume intake was good, but the controversial factor was high-fat diet. There is 23% reduction in mortality. And another controversial factor is that LDL does not produce major coronary artery disease, especially in Indians, are less important. And a high-fat, low-carbohydrate diet is beneficial. Saturated fatty acids is better than carbohydrate. This is the outcome of the study, but this was not well discussed. The whole PURE study was not very well discussed in scientific forum. We have been taught that all these years, the conventional wisdom that good cholesterol is good, but it is not so. High amount of HDL is bad. We have a lot of papers where extremely high-density lipoprotein cholesterol is paradoxically associated with higher mortality in men and women. So more important than the cholesterol discussing, is very difficult to conduct a study on cholesterol and eating pattern because there's so much of difference in genetic, racial, ethnicity, geographic variations. The people in Pima Indians, the dietary pattern is different from from other Chinese are different, the Japanese are different, Asian Americans, Asian Indians are different, migrant Indians are different. So we have a lot of ethnic variations. LDL, low or high, both small dense LDL is matters. And LDL metabolism and PCSK9. The LDL is most important. How much LDL is being internalized by PCSK9 receptors are more important. LDL moderate is okay, but high and low are bad. Non-HDL particles better than LDL alone. Total cholesterol and HDL ratio is important. Triglyceride and HDL ratio is important. ApoB, ApoA ratio, invisible fat in the diet is another important. You don't need to substitute fat in the diet at all. But about last year, there was a British Journal of Hospital Medicine. There is a big article on statin wars. Have we been misled about the evidence? But there is a fitting reply given by the European Heart Association stating that anti-statin lobby strikes again. Time to keep the record straight. And there is a very good article, one can read that. And they all went on saying that negative statin-related stories decreases persistent and increased myocardial infarction and cardiovascular mortality, increase the risk of myocardial infarction when you discontinue the statins. So there are a lot of papers in the press against and for statins. And why there is a conflict of interest for statin alone? There are so many drugs. Ezetimibe is there. Fenofibrate came and did not produce a much beneficial effect. And nicotinic acid went out. And PCSK9 has to take up. And there are a lot of triglyceride inhibitors like APO3 inhibitors and CETP, that is cholesterol ester transfer protein, toxicabib, miserably failed. Angiopoietin-like protein inhibitors and did not reduce triglyceride. Lipoprotein A little inhibitor and ApoE Milano came with a very big bang, but it did not raise the HDL, and HDL raising HDL did not produce reduction in coronary artery disease or acute coronary syndrome. So, but statins are there, concentrating only on the statins. There's a big anti-statin lobby. The ACC 2018 guidelines said that clinical atherosclerotic cardiovascular disease reduce LDL-C with high-intensity statin therapy or maximally tolerated statin therapy. So now we have cholesterol. Can cholesterol be used to fight COVID-19? SARS-CoV-2 infected cells began to accumulate large amount of lipid droplets. Lung cells are not designed to hold fat, which could explain some of the severe damage to the lungs. The virus is dependent on glucose uptake, cholesterol production, fatty acid. So statins and fenofibrate are being tried. So we have been learning medicine only from standard textbooks and standard journals, not from various social medias. Please use the media to report positively on statins and cholesterol lowering for the benefit of your patient and society as a whole. So to conclude my talk, the good aspect of cholesterol is essential nutrient required by every single cell of the body to function properly. Cholesterol is necessary for every steroid hormone which is synthesized from cholesterol, including sex hormone and adrenal hormone. Cholesterol helps to convert sunlight to vitamin D in the human body, which is very important for the body, called sunshine vitamin, boost our immune system. And the bad part is the conventional wisdom lipid hypothesis stays. The bad part is mainly about propaganda. And the conventional wisdom lipid hypothesis stays. Dietary cholesterol is definitely a nutrient of concern. LDL of 50, there is no atherosclerosis. Saturated fatty acid is still bad, but choose your saturated fatty acid. Fatty acid from eggs and a high meat are bad. Trans fatty acid is the worst. Repeated oil, frying oils. Saturated fatty acid should be replaced by PUFA and MUFA. Replacing saturated fatty acid with carbohydrate is not good. Carbohydrate itself, we have good carbohydrate and bad carbohydrate. Reduce it from 65% to 45%. Coconut oil is still a nutrient of consumption for overconsumption. You can add coconut oil with other oil, but the over controversy continues. Invisible fats form 40% of the Indian diet. If endothelium is good, no atherosclerotic cardiovascular disease. The ugly part is influence of food industry on nutrition. Anti-cholesterol and anti-statin lobby has made a big havoc. Irresponsibility on the part of social media, internet, Facebook, WhatsApp create confusion in the mind of common man. Doctors also forward such messages without giving a fitting reply. Plenty of reports were increase in sudden death and coronary artery disease when statins are stopped. In Greek mythology, we have three gorgons. Gorgons means demons, Steno, Uriel, and Medusa. We have one is saturated fatty acid, another is small dense LDL, non-HDL, another is high carbohydrate. Thank you. Can I stop sharing? Yes.
Thank you, Balendran sir, for the wonderful presentation. It's a very highly controversial topic, and you have made it very clear as to where the physicians and the doctors are to be. And next we are going to take questions only at the end. And once again, we have a very eminent academician to follow. Recently, only we had a great academic feast in Trivandrum. That was the JPEF annual convention. This year, we were very much concerned whether this JPEF annual convention, this program, all this will happen or not. And Dr. Jyotidev has clearly shown that it is possible, even in this COVID era, to go ahead with all these academic events, and they have done it wonderfully well. Now to be followed by Dr. Sabir here. Now I request Dr. Sunil Prashov to introduce our next speaker, none other than Dr. Jyotidev Keshavda, who is very familiar to all of us.
Thank you, sir. So the next talk is going to be dealt by Dr. Jyotidev Keshavdev, sir. He is the chairman of Jyotidev Diabetic Research Center, Trivandrum, Kochi, Attingal. He is vice president of Aero, and he's a fantastic speaker. We all know him, and he has got several fellowships, and he has done orations and lectured in many forums in India and abroad. The topic is a very, very interesting one, and we all know that of late there has been so many unconventional and non-evidence-based therapies, especially in the field of diabetes, has been happening. And Sar is going to talk about the perils of non-evidence-based therapies in diabetics practice in this COVID era. Over to you, sir.
Thank you, thank you. So let me share the screen. First of all, thank you very much, Mohan Nair sir, and my dear friend Sunil Prashov for the nice words, and congratulations to Dr. Shabir for this very successful event, and thanks for inviting me too. So as rightly said by Mohan Nair sir, we were very successful in conducting a JPF this year, and we all believe that education should continue. And so let me now proceed. And my title is on perils of non-evidence-based therapies, especially during this COVID era. So these are very troubled times for all of us. So I thought that I will start with a lighter note. The union minister who originally claimed puppet for a COVID cure has ultimately tested positive for COVID. And this is another very interesting page from Wikipedia documenting millions of fake COVID-19 treatments, millions. So when we people in modern medicine are busy with exploring newer investigations for COVID and exploring newer therapies, including vaccines for COVID, the guys in other so-called specialties or branches in medicine, they are busy propagating these unproven remedies. And this is from Africa, an unproven herbal remedy against COVID-19, now proven to fuel a drug-resistant sort of malaria. And this is a warning from the scientific world. And we, the Kerala guys, are also now very popular. So we are now infamous, very infamous. And this is again in the international media. Our own self-proclaimed naturopath was arrested in Kerala, and he has got a position now in the COVID-19 page. So very interesting, very interesting. And the question is, why is this happening? Why is this happening? So we have been listening to Bharachandran sir, we have been listening to Dr. Srijit and Kumar, and there are some similarities even in this presentation. Why are these unproven therapies still popular? So with COVID-19, there is anxiety all over. And this makes people more willing to try anything which is available, which gives them a sense of control of the situation. And many false claims are being circulated widely in WhatsApp, Facebook, and other social media, including YouTube. And some of these are claimed to be even from the World Health Organization, UNICEF, and so on. So the ordinary people and even the educated lot believe this. What are the effects? What are the after effects of such false propaganda? It ultimately gives a dangerous false confidence, increasing the infection rates. And people will go out searching for those remedies because these remedies are not widely available. And this encourages people to break the stay-home orders. and hundreds of people have died from fake COVID-19 treatments. In India, it can continue. But see, in the United States, the Environmental Protection Agency, this is one example, they have issued stop sale orders to Amazon.com and eBay regarding the third-party goods falsely claiming to kill COVID-19, threatening fines up to more than $20,000 for every sale of the product. Very brave effort. And now moving on to those unproven therapies in diabetes. And this is the news on a 13-year-old who died after being told not to take insulin. And now the herbalist is headed to jail. So this is the heading in Washington Post. In India, of course, this happens very commonly, but headed to jail rarely or seldom happens. Very unfortunate, very unfortunate. And I'm pretty sure that all of you, Mohan Nair sir, all of you will have hundreds of such experiences. And this is acupuncture and how fatal can be acupuncture. How fatal can be acupuncture. This is a guy around